Good afternoon, everybody. Welcome to Assembly Budget Sub 6 hearing. I'm very honored to be joined by a number of my colleagues today in person as well as remotely. You can see from here we have our Vice Chair of the committee, Mr. Obernolte, as well as our Chair of Sub 1, our Health and Human Services Budget Subcommittee, Dr. Rambula, and we're honored to have Dr. Wood, who chairs our Health Committee. My understanding is we have remotely, we have Assemblymember Reyes, who's chair of our Human Services Committee, Assemblymember Bloom, who chairs our Sub 3, Budget Sub 3 Committee, Assemblymember Fong, who's on our committee as well as Assemblymember, looking at anybody else on the Assemblymember Nazarian, who's chair of our Aging and Long-Term Care Committee. Today, we are again having a physically distant in-person hearing with a number of members participating remotely. We are following strict distancing protocols, and I will restate this when public comment begins, but any members of the public wish to speak, they will approach the microphone and we will have 1 minute of public comment, and we ask that after the public comment is made that they please leave the room. The panelists on the agenda are appearing remotely in both the Capitol as well as elsewhere in the state. There are also public stations available across the state to allow people the opportunity for public comment. The agenda contains the locations of these stations, including one in Capitol Park. If you have any problems, please call our Assembly Budget Committee office at 916-319-2099, and staff will be able to assist you. If you cannot attend the hearing but wish to submit testimony, please email us at budget, the word sub, S-U-B, the number 6, at asm.ca.gov. Just housekeeping items. After I make my opening comments, we'll welcome any comments from any of the committee members. We have panelists that will appear in the order of the agenda. And finally, once the members ask questions and that's concluded, I will open the hearing up for public comment. Now I'm going to ask the committee consultant to please call the roll. I'm looking at my committee consultant and asking her to please call the roll.
Ting.
Here.
Arambula.
Present.
Bloom. Cooper.
Here.
Fong. McCarty. Obernolte.
Here.
Weber.
Here.
Bloom is here.
Thank you very much. Perfect. As you know, we are here to do an oversight hearing over skilled nursing facilities. I do want to thank both my colleagues, Dr. Woods and Arambula, for having held previous hearings on this very issue. And the reason we are here again is because skilled nursing facilities have accounted for about 4,500 deaths, both amongst residents as well as staff. And unfortunately, this is a very high percentage of deaths within our state. Between this and our prison population, it's very unfortunate that we've seen so many fatalities in both of those communities. We wanted to revisit this issue by talking to both the agencies who have oversight over the skilled nursing facilities as well as those representing some of the facilities to really understand what's been done recently, what changes need to be done in the future. We fully understand that as this pandemic hit us in March, all of us were trying as hard as we can to understand what the pandemic meant and also to follow and develop protocols. Many of the protocols that have been developed have been learned through experience and us learning more about this COVID-19 virus and how it can be contracted as well as how is it spread. So I think this is a very important hearing for all of us just to hear what progress is made and also to alert the public as to what progress needs to continue to be made at the state level. I'm going to see if any other members of the committee would like to make opening comments. Mr. Obernolte.
Thank you, Mr. Chairman. I am honored to be here as a part of this panel discussing what is probably one of our most vulnerable populations in the state of California. We just want to make sure here that we are taking all appropriate steps to protect that population, not just from coronavirus, but also from the other concomitant problems that have come along with this epidemic. And I'm very interested in taking part of that and looking forward to the panel. Thank you, Mr. Chairman.
Okay, seeing no other comments, let's start with our first panelist, which is Ms. Steinecker with the California Department of Public Health. And I think in order for the screen to come up, you have to start speaking if you can hear me.
Hi, can you hear me?
We can hear you. Yes, perfect.
Cool.
Thank you.
Great. Thank you again. Dear members of the committee, thank you again for having me and having time today to discuss this important topic for California Department of Public Health's COVID-19 response, specifically to our most vulnerable Californians in skilled nursing facilities. As stated in previous hearings, CDPH took immediate action to learn from early outbreaks and implement new proactive strategies in skilled nursing facilities, as well as taken new actions to improve transparent communication to the public, including launching our new skilled nursing facility COVID-19 website in July that highlights strategies, provides real-time data, and shares interactive graphs, including comparison graphs to us and other states. And it gives up-to-date facility information for families concerned about their loved ones and ability to visit. It's also important to note CDPH reopened skilled nursing facilities in California on June 26th by requiring ombudsman entrance and requiring outdoor visitation and/or indoor large communal space visitation at all facilities. And most recently, as latest as last Friday, we issued a new revision to this policy that further opened up visitation options for in-room visitation in counties with lower spread rates. In our most recent efforts, we first met with local public health officers as partners in advance in hopes that we can have better alignment of our local public health orders and our statewide visitation policy. As a quick highlight, our biggest proactive actions we took were targeted COVID-19 testing and cohorting, implementing and enforcing COVID-19 mitigation plans. We go on site and enforce those every 4 to 6 weeks, expanding statewide infection prevention and education resources, and implementing predictive analytics and real-time alert dashboards to mitigate high-risk facilities. Some of the outcomes of our interventions I'm here to share with you today is that so far, these actions have proven to be notably successful with significant reductions in cases and mortalities at SNF statewide, while even community case rates have had surges in late summer, and even when we've seen various spikes during pandemics in the pandemic of hospitalizations. Despite the high case rates of COVID cases in counties in August, as well as high rates of hospitalizations in California in late summer, the skilled nursing facility case rates and mortality rates continue to stabilize and decline into the fall. For example, in May, the overall mortality rate in California in a skilled nursing facility was 8.6, and as mid-October, it is now reduced to 1.9. The COVID-19 mortality rate in May in California was 2.2, which has now been reduced to 0.4. In addition to this, when we look at comparing California to other states, California has by far the most SNF facilities and residents than other states. In some cases, we have triple or double or even sometimes quadruple the amount than other states. But the states most similar to California that we can compare to as far as resident populations are New York, Texas, and Florida. While COVID-19 specific mortality rates are now lowest in New York now, after a huge spike in February and March, California has lower COVID-19 mortality rates than Texas and Florida, and California's overall skilled nursing facility mortality rates are lower than all states by significant margins. As of mid-October, Florida's mortality rate is 5.1, New York is 4.8, Texas is 4.1, and California is 1.9. However, we know that in preparation for flu season, for a potential post-fall winter holiday spike after Halloween, Thanksgiving, etc., and after a potential second wave surge, recently we've also seen some facilities with new outbreaks 9 months into the pandemic. Although we have fewer facilities with these issues, we have looked at recent root causes to these outliers to identify new interventions going into the winter season. The first new intervention that we're looking at is this week and next, CMS is providing technical training and assistance to all of our mini staff, our new staff and existing staff on leveraging federal regulations, which are stricter in regards to infection control processes, and envelop them into our systems we've created for pandemic response. The second approach is that we are expanding our predictive analytics. Some of the most recent outbreaks that have happened are due to violations not necessarily under CDPH's jurisdiction, but out of violations from our partner compliance and regulations. And so now we will be expanding some of our high-risk predictive analytics data by partnering with other departments like DHCS, Department of Healthcare Services, Department of Social Services, OSHPD, and Cal OSHA, so that we can look at compliance data from other regulatory departments and see if there are high-risk themes that we can put into our algorithms. We'll also be including flu outbreak data from prior years so that we can also include that as far as a high risk for an outbreak. And we'll also be looking at childcare outbreaks within the same zip code of a skilled nursing facility, as that is usually an early indicator of a community spike. And we also have new outbreak demographics that we have acquired from CMS that we can also use as further data to use in a predictive model. We'll also be reassessing staffing. We are working with stakeholders to develop new staffing strategies for surge that will be published in an upcoming All Facilities letter. Some of those strategies include targeting infection control strike teams to locations with short staffing to re-educate of proper cohorting, and have surveyors reassess emergency staffing waivers for those facilities who have not provided adequate safe staffing level plans or who have not maintained safe environments for both staff and residents. And last but not least, we are partnering with the Department of Healthcare Services to look at quality and accountability supplemental payment incentives. We've noticed that many in public health and in the healthcare delivery system are experiencing burnout and pandemic fatigue after incredibly long hours, 7-day work weeks, and insurmountable stressful situations for 10 months. Some healthcare workers and facilities have switched to new protocols and established a new normal in how they operate under a pandemic, whereas other facilities sadly are still struggling to maintain this level of infection control precision that is required at all times, particularly when working with residents who may not be compliant in wearing masks or residents who may wander in cohorted zones. CDPH, in partnering with Department of Healthcare Services, is working on this AFL, which provides QASP incentives for facilities who demonstrate compliance with CDPH COVID mitigation requirements, and this will go into effect in January. CDPH was only able to effectively implement these strategies and further strengthen facility infection control response by working in real time with our local public health departments, county leaders, and also by working together with our fellow departments, with the Department of Aging, Department of Social Services, Cal OSHA, OSHPD, Cal OES, EMSA, to name a few. I also want to thank the many stakeholders and geriatric specialists, including the Geriatric Council, which today's panelist, Charlene Harrington, is on, as well as today's panelist, Mike Wasserman, who partners on weekly statewide webinars with CDPH. We deeply appreciate these opportunities to continually engage with, sometimes on a daily, if not weekly basis, to discuss both short-term pandemic response and long-term needed reforms. And finally, before we open it up to the rest of the panelists, I want you all to know, and for those of my staff who are listening today, how deeply grateful I am to all of our CDPH staff who have spent these last 10 months away from those they love to help California, especially all our staff in the field who are HAI infection control strike teams, our facility surveyors who get tested weekly and enter facilities 7 days a week, sometimes hours away from home, during long days and nights through wildfire evacuations and public safety power shutoff emergencies to help make sure all Californians are safe. They are humans by birth, civil servants by choice, but they are absolutely heroes in this pandemic. Thank you.
Thank you. Next, we are going to go to Lindy Harrington with the Department of Health Care Services, who's testifying on the phone.
Afternoon. Yes, this is Lindy Harrington, Deputy Director for Healthcare Financing with the Department of Healthcare Services. I'd like to thank the committee members for the opportunity to provide information today regarding skilled nursing facilities within the Medi-Cal program. The Medi-Cal program reimburses freestanding nursing facilities level B and freestanding subacute nursing facility level Bs on a cost-based facility-specific per diem reimbursement rate that is developed by the department utilizing a rate methodology based on 5 cost categories subject to percentile caps. The rates are updated annually based on the most recent audited cost report data, and skilled nursing facilities are also required to pay a quality assurance fee on their total bed days regardless of payer. The fee amount is calculated annually based on aggregate facility category revenue as reported by the California Office of Statewide Health Planning and Development. The Medi-Cal per diem rate includes an adjustment to fund the facility for the fee associated with their Medi-Cal bed days. Both the rate methodology and the quality assurance fee were reauthorized in state fiscal year 2021 budget trailer bill, which extended the methodology through December 31st of 2022 and included the following updates to this methodology. The rating period is being converted to a calendar year with an August through December 31, 2020 rate period as a bridge. For this bridge, facilities will receive a 3.62% weighted average rate increase. They'll receive a 3.5% increase for calendar year 2021 and a 2.4% increase for calendar year 2022. We also updated the peer groups for determining the cost category caps and peer group rated averages, and those have been redistributed and increased from 7 to 11 peer groupings. This will provide a more accurate rate to local cost conditions and prevent the methodology from artificially inflating some cost caps. The benchmark capped payments for direct labor and indirect labor costs were increased from 90% to 95% in order to further incentivize patient care expenditures. The Quality and Accountability Supplemental Payment Program, also known as QAS, was extended through April 30th of 2022. DHCS is partnering with CDPH for an all-facility letter which provides QASP incentives for facilities who demonstrate compliance with the CDPH COVID-19 mitigation requirements, and this will go into effect in January. Additionally, the department is in the introductory stages of considering how the next iteration of the payment methodology for freestanding nursing facilities that would take effect January 1, 2023. DHCS will convene a stakeholder process no later than September 1st of 2021 to develop a successor supplemental payment or quality-based payment methodology. DHCS is exploring additional methodology changes, such as utilizing the existing infrastructure of the QAS program to include an appropriation of 30 to 55% of the annual weighted average rate, to increase quality benchmarks as measured through QAS, increase quality payment frequency, or include quality payments as an add-on to the regular per diem base rate. Related to the COVID-19 pandemic response, DHCS provided a 10% rate increase to help cover the costs related to COVID-19. These costs could include, but are not limited to, increased staffing costs, medical equipment costs, sanitizing costs, PPE. DHCS is currently developing a methodology to audit the COVID-19 related expenditures as part of our annual cost report auditing program to ensure that facilities are spending this 10% increase of funds in appropriate ways to maximize infection prevention and control. According to National Investment Center for Seniors Housing and Care, the average Medicaid increase countrywide was 5% in response to the public health emergency. For example, Oregon provided a 10% rate increase from April 1st through June 30th of 2020. The District of Columbia provided a 20% rate increase to nursing facilities through the end of the national public health emergency. Washington State provided a per diem add-on reimbursement of $29, which will end the last day of the calendar quarter in which the public health emergency ends. For comparison, the California 10% equates on average to a $24 increase. It is too early to determine or measure the impact of the rate increase on facilities at this time due to lack of data, but I think as you heard from the previous panelists, we are seeing great things in our facilities. Now, within our facilities for Medi-Cal, clinical laboratory providers providing specimen collection for COVID-19 testing for residents in skilled nursing facilities are eligible to bill Medi-Cal. The clinical laboratory providers are eligible to bill for the diagnostic test and the specimen collection services separately. For COVID-19 testing for skilled nursing facility workers, coverage for the cost of testing will vary by the specific circumstances of the worker. For skilled nursing facility workers with symptoms of COVID-19 infection or who have been exposed to someone with COVID-19, workers can be tested at any testing provider and their health plan must cover the full cost of the test. For skilled nursing facility workers who do not have symptoms or a known or suspected exposure to someone with COVID-19, their state-regulated health plan must cover their COVID-19 test. However, the worker must go through their health plan to be tested in-network, and the worker is liable for normal cost sharing. Again, I want to thank the committee for having me here to testify and look forward to your questions after this panel.
Thank you very much. Next, we have Dr. Michael Wasserman, who's the past president of the California Association of Long-Term Care Medicine. Dr. Wasserman.
Thank you. Chairman Ting, committee members, those who say we didn't know what was coming to nursing homes in March and April weren't listening to the experts in geriatrics and long-term care medicine. On March 9th, I told NBC News that the coronavirus was the greatest threat to nursing home residents that we have seen. On March 25th, I told CBS that nursing homes could become our killing fields. My experience as a clinical and quality expert, in addition to having been the CEO of the largest nursing home chain in California, gave me a unique perspective into COVID-19 and the measures that need to be taken to reduce its impact and devastation. I want to thank Assemblyman Wood for bringing AB 2644 into law. Its requirement of a full-time equivalent of an infection preventionist in every nursing home is the type of workforce change that is necessary to protect vulnerable nursing home residents. But it's only the beginning. I come here today as immediate past president of the California Association of Long-Term Care Medicine and current chair of our Public Policy Committee to make recommendations that are actionable and sustainable as we move forward. Today's nursing homes are essentially mini hospitals, regardless of whether they deliver post-acute care or provide long-term care to the most frail, complex, and challenging population of patients in our history. The average nursing home resident has multiple chronic conditions, cognitive impairment, and requires professional oversight and care from a broad array of caregivers and healthcare professionals. Historically, a major role of the nursing home administrator has been to put heads in beds. The medical director, by federal regulation, is supposed to be the clinical leader of a nursing home. In usual practice, unfortunately, medical directors are often separated from clinical policy discussions and decisions. Registered nurses, as professionals who are trained to assess patients, are sometimes not available to make necessary assessments in real time. How do we run mini hospitals without the clinical leadership and staffing that are so vital? COVID-19 has brutally exposed this weakness. There is now ample literature to demonstrate that 24-hour RN coverage and a minimum of 45 minutes of RN staffing per resident per day, along with enough LVN and CNA coverage, leads to fewer COVID-19 outbreaks and deaths. Consultant pharmacists must also be engaged to the fullest extent. I can tell you, based on over 30 years of experience in the field of geriatrics, that having a competent and engaged medical director to work with the nursing staff and the infection preventionist, as well as to guide administrators who have little clinical expertise, has played an important role in battling this scourge throughout the state and country. I am a faculty member for the American Board of Post-Acute and Long-Term Care Medical Director Certification course. as I recently participated in the 3-day course that completes the training. All I could think of was what a difference it would have made if every nursing home in the state had a certified medical director over the past 8 months. I guarantee you that if that had been the case, and in conjunction with the appropriate nurse staffing levels, far fewer nursing home residents would have died. Every nursing home in the state already has a medical director, and nursing home owners already spend a significant amount of money on medical director stipends. By requiring certification, you will assure that nursing home medical directors have the tools, the skills, and the professional obligation
Dr.
to
Wasserman, can you
provide
hold on for
qualified oversight.
Dr. Wasserman, can you hold on for 1 second?
Yep.
I'm getting
Sure.
one of the remote members cannot hear the speaker. Is there a way to, can you check the audio?
Oh, no, that's probably because of the same issue.
Thank you for your patience, Dr. Wasserman. If you could just hold on 1 second.
Oh, no problem.
Let's just do a test.
Testing 1, 2.
Testing 1, 2. If can one of the members who texted me just text me back? If you could keep speaking, Dr. Wasserman, and just text me back to confirm that you can hear Dr. Wasserman.
Okay. So every nursing home in the state already has a medical director. And nursing home owners already spend a significant amount of money on medical director stipends. By requiring certification, you will assure that nursing home medical directors have the tools, the skills, and the professional obligation to provide qualified oversight. This will not increase costs to the state or the industry, but it will improve quality and accountability. There is also evidence-based literature that demonstrates a correlation between for-profit status and the size of COVID-19 outbreaks and deaths. The motivation for profit must sometimes be reined in to avoid harming the customer. Manipulation of existing related party transaction reporting can also skew actual facility level profitability. This is why we must have complete transparency around the ownership structure, as well as giving strong consideration to a medical loss ratio parameter for nursing homes. Last, but certainly not least, CNAs, the true heroes of this pandemic, must be treated with the respect and dignity they so richly deserve and finally earn a living wage. I also encourage you to pay extra attention to the comments of Nicole Howe and Dr. Charlene Harrington. I respect and value their insight and opinions. Thank you for this opportunity, and I look forward to answering your questions.
Thank you, Dr. Wasserman. Next we have Maria Carmen, who's a certified nursing assistant representing SCIU. And she'll be testifying with the assistance of a translator. So please go ahead, Ms. Carmen.
Adelante, señora Carmen.
Hola, mi nombre es María del Carmen Vázquez. Trabajo para la empresa Vallista. Soy CNA por casi 27 años.
Hi, my name is Vasquez. I'm a skilled nurse facility for Country Villa in Bay Vista.
Nunca me ha tocado una pandemia tan fuerte como ahora. Siempre estamos expuestos a muchos virus.
I've never been through such a tough pandemic. We're always exposed to different viruses.
Por más que traté de cuidarme, fui contagiada.
As much as I tried to protect myself, I became infected,
Y infecté a mi familia.
and I infected my family.
A dos de mis hijos, a mis dos nietos, a mi nuera y a mi esposo.
2 of my kids, 2 of my grandkids, my daughter-in-law, and my grandsons.
En esta semana salimos muchos compañeros infectados y pacientes.
During the week, there was a lot of patients infected and a lot of nurses infected. but my husband had it bad. He was 10 days intubated in the hospital. I, I couldn't be there with him because hospitals are not allowing members to be there with patients in the hospitals. We had to wait until the night time for a nurse to do us a favor to keep an update so that we can see him. And that's how we lived that nightmare for 10 days. For us, our nightmare was over after the 10 days, but for my husband, it had just started. When he woke up with his hands tied and with the tube in his mouth. He thought he was kidnapped because he couldn't remember anything that had happened to him. He didn't know he was in a hospital or what was going on with him. They started to explain to him that he was infected with COVID. And he thought that me and my son were in another hospital, probably the same or worse. And he also thought that we were dead because we were not with him when he used to talk to us. We continued to be like this way for about 5 weeks. He didn't know that we were all infected. And things haven't changed at the convalescent center where I work. We still wear simple gowns and simple masks. But this pandemic is very strong. You can carry it in your hair or in your shoes. This pandemic has been very hard. It has affected me emotionally, financially as well. I stopped working since July 10th. My husband is already retired, and I'm running out of my savings. And right now, I am scared to go back to work because I fear to become infected again. And also to infect my husband. He made it through this wave. I don't know if he will make it through the next one. And so I am very scared. And I don't know. This is real, gentlemen. This is no simple flu. This is real. I do not go out on the streets. I fear of getting infected or to infect other people. It is very sad and scary to be infected. It is really sad to have your family drop your food on the door, feeling like you're some kind of infected with some kind of weird disease. I've always been a very independent woman. I've always worked hard to support me and my family. I have never depended on any government agencies or any government services. I've always supported myself. And it's really tough to see your family drop food on your door and not be able to touch them. I hear the news and I hear the president speak some stuff that I don't believe because I went through it with my family. I don't know what else would you guys like to know.
Okay, thank you very much, Ms. Carmen. We very much appreciate your testimony and frankly for your service. We're gonna, is Ms. Carmen done? Okay, then we are gonna, if you could stay available for questions, we are gonna move to our next speaker, which is Nicole Howe, the Executive Director of Ombudsman Services of Contra Costa, Solano, and Alameda. Ms. Howe, once you start speaking, it'll move to you.
Wonderful.
Thank you.
Thank you. Thank you, Chairman Ting, for inviting me to testify before you and this distinguished subcommittee. My goal today is to help paint a picture for you and the other members participating today, as well as the public, about the state of long-term care in California 8 months into the pandemic. And as we look at long-term care, I want us to think of a broader view of what this looks like. We're talking about skilled nursing facilities, but I ask that we consider all 308,000 individuals living in long-term care in California in both residential care facilities for the elderly and skilled nursing facilities. So as you know, as a long-term care ombudsman, I, along with thousands of people across the country, are charged with assisting residents and families to resolve issues of neglect, poor care, bed sores, eviction, and discharges. And often, we are the only people who families have to turn to help them resolve these issues. But for nearly 6 months, long-term care ombudsmen, like so many licensing agencies, were prevented from entering facilities, leaving residents highly vulnerable to poor care and lack of support and advocacy. And I think sometimes what we hear in these hearings is we hear the amazing state plans, but we don't always understand how those affect the individuals on the ground. And so I, like all of you, don't necessarily participate in individual care meetings. But last week I had a staff out on vacation, and so they let the boss sit in and help out. And I heard an perfect example of what has been going on in skilled nursing facilities since ombudsmen have not been part of the day-to-day operations. We had a resident who'd been in a skilled nursing facility for many years, who the great family, they had a caregiver that helped to provide care 25 hours a week, But during COVID, she had lost nearly 20 pounds. She began to develop pressure sores. So the family, in good faith, got Medicare, hospice involved that is paid for by Medicare. The facility was already being paid via Medi-Cal. The caregiver that was coming in the facility was feeding her some of her meals each day and was taking the time that she needed in order to ensure that she retained weight. And when we talked to the facility about ensuring that she had adequate wound care, as well as someone to sit with her just twice a day and spend 25 minutes feeding her, the response was, we don't have time for that. And I think that is the true story of what we're seeing, which is facilities, maybe well-meaning, who are very busy, but without proper oversight, we are seeing a significant decline in care and the quality of life for residents. And I think this is a great example of the issues that COVID-19 exploited. They're not highly technical or complex. They're basic issues of staffing, management, leadership, and infection control. Now, in California facilities, this summer, when there were patients with one COVID-19 infection, those facilities had, on average, 25% fewer registered nurses in the building at the end of 2019. That should tell you a lot of things, but one of those is that RNs take no guff, and if they are in buildings and present in buildings, that they drastically improve care. The other part of it is that as of this summer, about 91% of the facilities that had active COVID-19 outbreaks, 91% of those had a prior violation related to infection control. That means they were cited for an issue when they knew that the licensing entity was in the building. And I don't say this to indict the facilities, but I do this to say that we've had a demonstrated history of a lack of enforcement in facilities, and we could identify where the problem issues were going to happen. Now, poor staffing in long-term care facilities was and continues to be the gasoline to COVID-19's match. Within the long-term care industry, direct care workers, on average, earn only $1 to $2 more per hour than minimum wage to do the most critical work that we have to care for our older and disabled adults. These dedicated people work 60 to 80 hours per week, often at multiple locations, to pay the most modicum and modest of rent and expenses. Meanwhile, you may have a caregiver because of the system that is working at multiple long-term care facilities, meaning they could be working at facility A where there is a current active outbreak, and they could then be going to care at facility B. And this practice is not expressly prohibited by our licensing bodies. Now, in order to address these critical issues I've raised for you today, I want to talk to you about a couple recommendations. And the first, and I think this echoes Dr. Wasserman's sentiments, is we need to require long-term care facilities to immediately raise compensation for certified nursing assistants and caregivers 30%. And I know that might seem like a lot to you, but I want to give you a sense of what that really is. Talking about $3 an hour. These people are doing critical work, and we need to help maintain and retain the industry. And again, you're probably like, but Nicole, we already don't have enough caregivers. And that's where I'm going to tell you a little bit of Elizabeth Warren, which is that I have a plan for that. In Contra Costa County, we have created the Healthcare Career Pathway, which is a comprehensive training program for certified nursing assistants that is both person-centered, is based in reality, and has comprehensive support for the students. And we have nearly 100% graduation rate. And we hear from the facilities that the CNAs that complete that program are more akin to people who've been working for a year in the industry. And what's important to know about that is that it's very challenging to create certified nursing assistant programs. The required curriculum by CDPH is particularly prescriptive and restrictive and allows very little movement, frankly none, for what the realities of caregiving are. And so I ask you today to dedicate a statewide task force to review the current training protocols for CNAs and allow this task force to be bold and to be innovative and propose updates to the training curriculum and the testing process. There are currently CNAs who completed training during quarantine. During COVID, they completed their training, but they've been unable to test because there is such a backlog at testing centers. Meanwhile, we have issued staffing waivers to allow skilled nursing facilities to operate at less than optimum staffing. Next, I'd like us to talk about a comprehensive strike team. I have seen when there is an outbreak, there is still a gap between the licensing entity, be that CDSS or CDPH, and local public health. And the problem is because those entities are not normally in facilities every day, there is a lack of discernment for those bad actors who would choose to use a situation to not be entirely transparent. Additionally, when there is a problem with staffing, all too often facilities are given a list and told to call staffing agencies. When what we need to, as enforcement entities, we need to come with trained CNAs who are prepared to work on the ground immediately. We cannot simply send in well-meaning and well-trained EMTs who are not able to actually do the work, and this actually prolongs the outbreak and I believe diminishes care. We need to direct CDPH and CDPSS to adopt a more proactive approach as it relates to emergency planning. We can no longer simply say to review an emergency plan of a facility. There needs to be an approval and a clear distinction to ensure that their plans are ready. For example, in Sonoma County, there was evacuations and facilities evacuated to a local evacuation center. So they took frail and older adults in the middle of the night to a place where they are around many more people without a plan to move those people to additional facilities. We need to be clear about when we're evacuating, where residents are going, and the transportation plan to get them there. We also need to gain a clear commitment from both CDPH and CDSS about their return to normal operations and ensure that no one reverts to technical assistance. We need our enforcement agencies to be enforcement agencies and to be enforcing the regulations that we, the people of California, have fought for over many years. Thank you so much for your attention to this issue. I hope that you will continue to focus on this long after COVID-19. Again, the issues we're seeing happen today are not so much an issue of COVID-19, but of far too long that we have not given enough attention to those older and individuals who experience disabilities. Thank you so much.
Thank you, Ms. Howe. Next, we have Dr. Charlene Harrington, who's a professor at the University of California, San Francisco. Dr. Harrington.
Thank you. Thank you very much for the invitation to speak today on behalf of myself and my colleagues at UCSF, at Cal Hospital Compare, at UC Davis, and USC. Since March, California nursing homes have faced a humanitarian crisis. Residents are less than 0.5% of the population, but account for 27% of all California deaths. The good news is that legislative changes can be adopted that will save lives by addressing 3 areas. 1, improvements in staffing and wages. 2, increased financial transparency and accountability. And 3, increased oversight and enforcement. First, my colleagues and I have conducted 2 recent studies in California nursing homes showing that nurse staffing levels are the major factor that prevent COVID infections and deaths. Higher total staffing hours and RN hours reduce COVID infection and death rates by half. We found that California's minimum staffing standard of 3.5 hours per resident per day is simply too low to protect residents. We urge increasing the state's minimum staffing law to 4.1 hours per resident day for total nursing, including 45 minutes of RN time and 24-hour RN coverage. We also strongly recommend eliminating all staffing waivers, which only serve to reduce and keep wages low. In addition, we found that nursing homes with over 50% turnover rates were 30% more likely to have higher infection rates. We urge requiring a 15% increase in nursing assistant wages in the coming year to reduce turnover, to reduce the staffing shortages, and prevent workers from working in multiple different facilities, and to increase work productivity. Second, early in the pandemic, California for-profit nursing homes had 4 to 5 times higher COVID infection rates compared to nonprofit and government facilities, probably because they were not spending adequate amounts on direct care services. So we have two recommendations. One, requiring that nursing homes submit an annual consolidated financial report by a certified auditor for all related party organizations and entities, including parent, management, and property companies. And second, establishing financial limits on administrative costs and profits on the entire nursing home company so that the remaining funds can be used for direct care services. New Jersey has just passed such a law requiring 90% of expenditures for direct care services. Third, California has a long record of a weak survey agency oversight and enforcement. We recommend two things. One, establishing clear quality criteria for any new owner or any changes in owners or management of nursing homes, and actually enforcing these requirements in order to force a sale of facilities to more responsible owners when it becomes necessary. And second, strengthening the oversight and enforcement, especially in at-risk facilities, using penalties, bans on admission, and temporary managers. And at-risk facilities include those with low staffing, high turnover, for-profit ownership, large facility size, and facilities with high percentages of minority residents, with male residents and older residents. Finally, to provide better tools for monitoring, oversight, and policies, we also recommend giving CDPH and OSHPD authority to obtain data on resident characteristics and payroll staffing from CMS, and to make these available publicly and to use those for monitoring high-risk facilities. And finally, establishing a Center for California Nursing Home Research that collects and integrates relevant data as soon as it becomes available in order to do rapid cycle research to support policy and legislative developments. So in closing, by addressing staffing and wages, transparency, and oversight and enforcement, the legislature can protect the health and safety of residents and staff from further COVID infections and deaths. And at the same time, it can tackle these long-standing quality problems that California nursing homes have had. Thank you very much.
Thank you very much, Dr. Harrington. Our final speaker will be Craig Cornett, who's CEO President of the California Association of Health Facilities. Mr. Cornett.
The California Association of Health Facilities, we represent over 900 skilled nursing facilities and over 400 intermediate care facilities for the developmentally disabled in California. I appreciate the opportunity to provide comments today about how skilled nursing facilities are responding to the COVID pandemic and the continuing challenges we faced from our perspective, and what improvements in state reimbursement and oversight could have a positive impact on the quality of patient care going forward. But I want to start out by just, first of all, thanking the workforce, the tremendous and tireless workforce in all health long-term care facilities in our state who do the best every day to keep our fragile elderly population safe and protected. CAF members and all of our long-term healthcare workers should be recognized for their dedication and sacrifice. I also want to talk a little bit also about how we have stepped up to the plate, and we are seeing significant stabilization of patient care through improved detection, containment, and prevention of coronavirus. You heard Heidi Steinecker earlier in the hearing give you the latest statistics. They are well outlined in pages 4 and 5 of your agenda as well. As of yesterday, there were about 700 positive residents in skilled nursing out of over 100,000, between 100 and around 100 to 120,000, about 700 positive residents, and only about 8 positive staff out of about 140,000 staff. So there's been tremendous improvement. But there are still challenges that require continued state support going forward. I'd like to start out by just telling you a little bit more about what we're doing now, and you heard some of this from Heidi. First, each facility is required to have and adhere to a comprehensive COVID-19 mitigation plan approved and monitored by CDPH. Mitigation plans are living documents, and they are frequently updated to address current circumstances. Second, testing is an essentially required element of facility prevention and containment of COVID-19. Residents are monitored daily and are tested if they have been exposed to a COVID-19 positive resident or healthcare worker. Anyone with symptoms is not admitted, and residents and staff showing symptoms are tested immediately. If residents or staff are COVID positive, they quarantine for 14 days and follow specific protocols. The CMS at the federal level and CDPH both require weekly testing of staff, which coincides with testing requirements in many local governments as well. Testing has improved greatly in recent months, and the results are coming back more quickly. And they are also reported to CDPH and to CMS and the Centers for Disease Control in Washington. Third, skilled nursing facilities are using a variety of required personal protective equipment, PPE, to protect their healthcare workers and residents with mandatory use of gowns, gloves, and masks. This PPE is much better available now than it was in previous months, and I would commend SB 275, which passed this session, which will require stockpiling of PPE to have it on hand for future pandemics. Fourth, facilities have increased infection prevention and cleaning. Each facility has a clinical staff member with advanced training designated for infection prevention and control that trains other staff on infection control procedures. Extensive cleaning of resident rooms, common areas, and high-touch surfaces have also increased, and those have helped reduce the potential COVID exposure. I'd point out also Mr. Woods, AB 2644, which passed this year and requires each facility to have an infection preventionist on staff for appropriate training for all staff members. Fifth, nursing facilities have increased staffing hours to allow more personalized resident care as communal dining and group activities have been canceled. Screening, testing, and reporting the COVID status of residents and staff to multiple agencies also requires additional staff time. Every extra staff time is being utilized to facilitate resident interaction with friends and loved ones. Activity staff have transitioned to providing room visits and activities to engage residents and keep them as active as possible. And finally, I want to mention visitation. CAF, my organization, strongly supports safe visitation practices. They are important for the emotional well-being and health of our residents, whether outdoor or indoor. Guidelines have been established by the federal government and by CDPH. The guidelines depend on the positivity rate in each county. There are significant restrictions to visitation based on a variety of factors. They are held most often outdoors whenever practical. Indoor visitation is allowed if there is no response, testing, or outbreak. Visits are conducted one at a time. Movement is limited, and visits are held in a single room or designated area. The core principles are maintained for visitation to occur, which include screening, hand hygiene, source control, physical distancing, and the like. I want to also thank the committee for looking at the important issues of nursing home financing, and thank the committee for the support of this year's budget and AB 81. That bill contained important reforms to Medi-Cal financing for nursing homes, and I want to highlight a few of those in what you passed this year. You continued the cost-based facility-specific Medi-Cal rate reimbursement structure, and you improved funding for direct labor cost. You made nursing home facilities accountable for the COVID-19 response as a condition of receiving additional increased reimbursement. You assured that the federal dollars for the pandemic are utilized and audited for specific pandemic cost. You created penalties for facilities that are additional penalties that are not for facilities that are not compliant with staffing and wage requirements. But I would just point out to you, even with the passage of this recent budget bill, Medi-Cal still underpays nursing facilities for patient care they provide. The Medi-Cal program is the primary payer for nursing facilities, making up about 70% of the long-term care population. The Medi-Cal reimbursement structure is structured with significant cost constraints and limitations. Facilities are incentivized to spend more dollars on staff wages, but they only receive a portion of those costs from the Medi-Cal program as reimbursement due to inherent capitation on funding for labor. Nursing facilities have an ongoing shortage of certified nurse assistants as well as LVNs and RNs. This happened long before the COVID-19 pandemic, and it has been exacerbated with the challenges as healthcare workers may need to quarantine for 14 days. Childcare concerns, the fear of contracting COVID have also made this more difficult. But even with all this, we have seen great progress in the control of the virus. To look at improving staffing in nursing homes, it's imperative that the state be prepared to actually pay facilities for their labor cost so that they can afford the wages necessary to recruit and retain healthcare workers. In addition, the state needs to assist facilities in recruiting and retaining the needed workforce through workforce development. Finally, beyond looking at more adequate Medi-Cal financing for labor cost, we want to suggest a couple of other items going forward that would have an immediate positive impact. Continuing to prioritize nursing facility residents and staff in everything that the state does. This will include the vaccine, the distribution of the vaccine, and I can talk more about that in the questions. There's a lot of positive things happening to prepare for the vaccine. Increasing the access of nursing facilities to testing kits that provide timely results. Although testing is getting better, there are still hurdles and cost constraints. Also, I just wanted to mention a few other things for the purposes of assisting in public transparency also. Right now, there is no clear website where anyone can access all federal, state requirements and local requirements in one place. We have urged the state to develop such a portal so everyone can understand everything in one place. A dedicated PPE for skilled nursing home care workers is going to be important going forward, as we will see gaps probably continue in the availability of equipment. And lastly, but no less important, the state must provide funding for nursing facilities to cover their costs associated with significant liability and workers' comp rates due to the pandemic. Nursing facilities rates are skyrocketing for pandemic coverage, and when they are lucky enough to even be able to find insurance coverage. In most cases, facilities are not finding carriers that will cover their liability or their workers' comp risk related to COVID. The last point I just want to make, Mr. Chairman and others, is skilled nursing facilities are not islands. The entire healthcare profession is still learning a lot about the disease, how it spreads, and how to contain it. Unfortunately, neither SNFs nor hospitals are islands, and we are all part of the community. Our communities, our employees live in the community, as do the vendors, as do physicians and specialists and others. When visiting ramps up, we will have family members from the community too. Facilities that have taken aggressive prevention practices, but they are not isolated, and what happens in the community frequently finds its way into buildings, even with the most aggressive prevention practices. Thank you very much, Mr. Chairman, and I'm happy to answer questions.
Thank you very much. Questions from the committee? Mr. Obernolte.
I have a couple of questions for the CDPH, if we could get Ms. Steinecker back.
That's what we should do, but you just said 2 separate chairs.
Yeah.
Okay, I'm back.
Thank you very much. So I know that we all share a concern about the effect that the lack of visitation has had on the emotional and psychological health of the residents of these facilities. So I'm wondering if the CDPH has some data on those statistics and the effect that the lack of visitation has had on them. Because I've not seen any data on that.
Thank you for that question. We have been working with the California Department of Aging and the Ombudsman program to look at data. One of the partnerships that we've had with the California Department of Aging is working with Ombudsman to find are there concerns for those that either have been back into facilities, or we are also providing technical assistance to the Ombudsman so that they can get into the facilities and see if we can glom out any types of quality of care data, et cetera. We also, when we go into facilities as license and certification surveyors, we're not just looking at infection prevention. When we're there, we're looking to see, are there issues with quality of care? Are there issues with leadership? Are there issues with nutrition? And there have been many citations that we've given throughout the course of the pandemic, or had to take even more aggressive options like putting in temporary managers or doing a revocation, et cetera, to those situations. But one of the things that does give me a little bit of hope after for your question about what are the long-term effects of some of this isolation is we were looking at overall mortality rate to see if the overall mortality rate is higher this year than last year or in previous years, and looking at what the effects of COVID mortality versus overall mortality. We are seeing low rates and lower rates of mortality in our skilled nursing facilities. But we think that that could be because the infection control practices are so much greater now that perhaps people are not exposed to other potential, as communicable diseases within and other things that can happen. But that's not to say that there aren't issues. We are tracking what types of complaints we're receiving, as well as facility reported incidences. And most of our complaints around visitation. And as I stated in my testimony, one of the things that was a factor is that when we issued and reopened facilities on June 26th, the state might have said, hey, we're reopening, requiring visitation. But many local public health officers had more stricter local public health orders that restricted ombudsman or would restrict visitation. And so when those came out, we then started to meet with public health officers one-on-one, talk through what the concerns were, because we do have concerns about isolation, and of course they do as well, but we're trying to partner together on the science and using science-based practices to say, hey, visitation should be a requirement. It is a patient right. And so we want to make sure that we have safe protocols to do so. So that's why before we issued this second visitation AFL to reopen further, we did a different practice. We first met with all the public health officers, asked for their feedback, and so when we issued that on Friday, our hope is that over the next week or so, we hope that the local public health officers that have stricter guidelines will now more align themselves with the state reopening, but again, with safe practices and protocols that we have listed out in our policy.
All right, thank you. The reason I raised the issue is that I have had personal contact from quite a few constituents, and I'm sure probably everyone on this dais has as well, very concerned about loved ones that are in skilled nursing facilities that they are unable to establish visitation with. And I do not share your confidence that the ombudsman are going to be able to highlight the extent of this emotional and psychological problem, because the data that I have says that we had almost 7,000 ombudsman visits to skilled nursing facilities a year ago in October, and that this month it's been around 1,000. So I'm concerned that we might not be getting the full picture of how pervasive this problem is. And I know that it's something that our constituents are very concerned about. So I'd like to ask if we can continue to work on this, because I think that there is probably a protocol that can be established that enhances visitation while still protecting the health of the residents of the facility.
Agreed.
Great. So my second question is about the state's VA facilities. I know that they serve a very large population in their skilled nursing facilities, but I don't believe that we've had any major COVID outbreaks in those facilities. And I wonder if you can talk a little bit about why that is and what disparities might exist between the VA and the other skilled nursing facilities in the states, because I found that very odd.
That's an interesting observation about the VAs. I can take that back and look more into that detail, because I want to be able to pull pull the data on that to see, because I don't have enough information at this time to be able to kind of speak to why that may be or why that may be. But I will definitely take that back as a something to look into for our analytics.
Okay, well, thank you. And if you can coordinate with my office on that, I was very interested in that.
No, that is interesting. You brought
Just
that up.
wondering if there might be some good lessons learned there, because obviously those facilities are doing something right if we're not seeing the same degree of outbreak there as we are elsewhere. All right, thank you.
Thank you. Next, we're going to have Dr. Rambula.
Thank you, Mr. Chair. And if I could, I wanted to start with a thank you as well to Maria Carmen, who had gotten infected while working in a SNF. I think it's important to recognize those who are on the front lines. Having been a provider myself, I understand and appreciate what pandemic fatigue looks like. And oftentimes it's when we don't start appreciating those who are working so hard right now. And so, Maria Carmen, I just wanted to make sure you felt it from us here on the dais, that we're here trying to figure out how to help to support you. But I did want to talk about what Craig Cornett said, because he said we didn't have a CNA problem, or we did have a CNA problem before we started this pandemic. And I think we really have to look towards ways we can support our workforce via retention or recruitment, and wanted to hear from you regarding the workforce development that you spoke about. And then if I can, I'm going to be queuing up Nicole Howe to come up and speak about the healthcare pathways that she referenced in her commentary. So if we could start with Craig Cornett.
Yes. Yes, thank you, Dr. Rambula. The workforce is so important to this sector, but it's not just to us. It's pretty much everyone in the entire healthcare sector right now. Workforce is a major issue. I was a member of the Master Plan for Aging stakeholder group that has just finished its work, and there's a major section in there about workforce development. This is going to take almost a national or statewide effort in terms of training, bringing in more healthcare workers, especially CNAs, but really in the nursing and the LVN and RN areas as well. And you've also heard today that some of the ideas of putting more money in for pay. Facilities would love very much to be able to pay more, but at this point they will need to have increases in rates to do that. There's just not enough money in the system to do that. I know this is a major issue at the federal level right now as well. I would just point out CAF, for example. We had a grant recently to establish more facility-based workforce training programs that was very successful, but we are so far behind the curve on that. It's going to take a while. The notion of being able to increase the workforce in a really fast way I think is very difficult to imagine.
Has the state, and this question will be directed towards the state, but have we ever looked at any outreach or PR campaigns that may help us to recruit more people into CNAs? I think it's particularly important now as we look at the economic conditions of our state to be providing pathways for many people who may have cultural or linguistic competencies.
Hi, this is Steinecker from California Department of Public Health. We have actually put into place looking at all the database from previous CNAs that we have and trying to match them to facilities where we say that there are openings or we know that there's regions that need more staffing. We've done some creative things around that around the pandemic, but when it comes to kind of PR campaigns, one of the things that I would love to work with some of our stakeholders, particularly I know Charlene, and I want to talk to Nicole Howe after this testimony, because I want to know more about what their program does, because one of the things I've noticed that we need to do as a state is even partner beyond public health, but I would love to partner with the Department of Education and start to provide vocational educational opportunities, much like we used to, decades ago, in even K through 12 and community college, and really have that CNAs and entering the workforce and having internships at a very young age as really having a pathway into our healthcare workforce system.
Thank you. And with that, if we can hear from Nicole Howe, and I will just say it was so pleasant to hear from you. I'm so used to hearing from Lisa Coleman, but understand why she gave you the seat today. So can we hear about healthcare pathways from you?
Yes, thank you. I appreciate the opportunity. The Healthcare Career Pathway is in its second year. It is a collaborative partnership between my program, Ombudsman, Opportunity Junction, a local job training organization, and Mount Diablo Adult Education, as well as Feline Sangha, a skilled nursing partner. And what we realized is there was a dearth of CNAs, but more importantly, there was a dearth of really CNAs who were committed to person-centered models of care. And so our model was we need to seek out individuals who have addressable barriers, meaning we are looking for students who have some challenges. If you could go and pay for a private CNA program, that's not our student. We want students who maybe they're the first in their family to go to post-secondary education. Maybe they've been homeless in the past. Maybe they've had some addiction issues. We believe that those people really understand the plight of those who are in skilled nursing facilities. Because I'm going to tell you a secret. Folks who are in skilled nursing facilities have not always had easy lives. And so we need other people who have maybe not always had easy lives who understand what that looks like and are sympathetic to that. And so we created a nearly 13-week training program that is comprehensive in nature. So not only do we have lunch brought in every day through loaves and fishes, the students go home with food from the food bank every weekend. It is very low cost or nearly free for the students. We work with skilled nursings and others to find funding sources. When a student has a challenge, if they show up late or they're angry, we don't assume that the problem is the student. We use root cause analysis to look at what are restorative models to address the situation, what system barriers are happening. And we graduated our third class in the middle of COVID. We had a drive-up graduation. We have an incredibly high graduation rate. And our students, not only when someone who came in a program who was challenged before that, when they have a skill and a job, they walk differently, they talk differently, and we hear from facilities how amazing they are in the facility. Now, there's a couple key things about this program. I believe community colleges are an important part of this education system, but adult schools are the hidden gem of communities. Many people who might be drawn to this or maybe first in their family to pursue this kind of entrance into allied healthcare, they maybe wouldn't feel super comfortable on a big community college campus. Adult schools are smaller, they are cozier, and when you pair that with a comprehensive network of not only soft skills that we're helping them to learn, but also comprehensive wraparound case management and support services, they can do amazing things. Now, I want to tell you what's hard about this is the required curriculum from CDPH is incredibly proscriptive. So it's very hard to slide in. When do you talk about death and dying? When do you talk about person-centered care? When do you address these things that are realities of working in the system? When the curriculum, the approved curriculum, doesn't necessarily allow that. We need a special, what I call a sandbox. We need a waiver program to allow us to look at these programs, what it would take to really fund them, and how can we expand that across the state. We also need pathway programs. We need real programs where we're working to build a home health aid program on that and add LVN. We need stackable programs where individuals are not having to repeat curriculum, but we have a constant stream of really qualified, certified nursing assistants and caregivers. And also, when they've been in there for a period of time and they've mastered that skill, be able to take that and move on to LVN and RN. Because as Craig says, we have a lack of LVNs and RNs in facilities too, and the need is only going to grow.
I want to appreciate your answer, and if I can, I want to follow up with my staff. I think you are setting an example that many of us will want to look at and see if there's potential for us to scale, and so would really like an opportunity to get more information. While Ms. Steinecker is coming to the microphone, I will just comment that it's hard not to look at the graph on page 4 and notice some correlation between when Ombudsman went back into facilities and we start noticing improvements. But wanted to just appreciate you, Ms. Steinecker, for the significant reduction in both cases and mortality. It's impressive what we're looking at, and just want to make sure you hear that from those of us here on the dais. But I want to turn to page 15 if I can. And in that, there is discussions regarding flu vaccinations for SNF workforce and staff. And so, Ms. Steinecker, I was hoping to speak with you if I could. There are established national goals for SNFs to have 90% coverage of the SNF workforce and staff. And I'm wondering, what is California's current workforce staff flu vaccination coverage?
So Craig Cornett may perhaps be able to provide a little bit more insight to this as well, as we've been talking most recently about flu coverage. And I believe it's in the mid-90s last that I had heard. So Craig, if correct me if I'm wrong, because I know that you had the stats on it.
Yes, it's in the upper 90s actually for flu vaccination for residents. For staff, it's not quite as high, but the way the rules have worked over the years for flu vaccination for staff is if staff do not refuse to have a vaccination, they have to wear additional PPE and masks throughout the entire flu season. This is going to be a different conversation going forward now, obviously, on the COVID vaccine, but the vaccination for residents is in the upper 90%.
And that gives me comfort, Craig, because in the agenda it highlights that approximately 60% nationally is what the average is for workforce. So if California is leading the way on that, I think that's important. Final question, if I can, for Ms. Steinecker, and I am trying to think a step ahead. And when we have a COVID-19 vaccine, I think there's going to be a discussion about prioritization. And I think it's an important conversation for us to think about. Should we be pushing our first responders to the front of the line? But I believe we also need to look towards our congregate care settings, our SNFs, and would love to hear Heidi Steinecker, what your thoughts on whether or not SNFs should be prioritized in COVID vaccinations.
Well, absolutely. And we do have a vaccine workforce task force right now that is looking at all the prioritizations across all of our healthcare facilities, as well as looking at who are the most vulnerable populations. The vaccine, obviously, many of the different options of vaccines right now do present some operational implementation challenges. For example, even the Pfizer vaccine that has to be stored at sub 70 degrees. And then can only have like a 12-hour thaw time before then you can, vaccinate. Otherwise, it's no longer efficacious. Some have various levels of efficacy for different types of populations, including many who would reside in a skilled nursing facility. And so I think the important message that we're going to have to come out very strongly and clearly is, much like we have had campaigns and information about how important it is that you mask, even if you're young, 20, 30, healthy-year-old, out there, it's important that you abide and your decisions in wearing a mask and what you choose to do to remain physically distanced and not do these huge gatherings and such, that directly affects our skilled nursing residents and our most vulnerable. And so much like with vaccines, we encourage vaccines for all ages in order to protect those who the vaccine might not be as efficacious for. So it's important that we kind of look at it not just from a priority of who gets the vaccine, but also having very strong public service announcements out there about why it's so important that everyone chooses to do the public health things like vaccines and masking and physical distancing to protect those who they might not be, who they might have interaction with.
Thank you very much.
Dr. Rangel, if I could add on to the vaccine issue, in the last week, the Centers for Disease Control in Washington has announced its prioritization for the distribution of the vaccine at the federal level. And Tier 1, the very first priority, is going to be skilled nursing residents, congregate care residents, and staff. The federal government, CDC, has already established a partnership program to distribute the vaccines and come to the facilities to vaccinate residents as soon as the vaccine is available and safe and ready to go. So that's going to be a huge leap forward. The state will be working with the federal government to establish how they're going to roll out the vaccine for healthcare workers. But this is well underway. It is going to be a daunting challenge, as you can imagine, and we don't know which vaccine is going to be the most efficacious at this point. Some have to be restored at minus 80 degrees, but the folks who are going to come into skilled nursing facilities to vaccinate the residents will have all of that. They'll have the PPE. They'll be able to do those vaccinations, and we're very much looking forward to that.
Thank you very much.
Thank you. I know we have Mr. Fong had some questions.
Yes. Thank you, Chairman Ting, for having this hearing. I guess my first group of questions will be to Ms. Steinecker. First, thank you for your assistance for us in the Central Valley. I think at the beginning of the pandemic, we had a number of congregated hotspots, and you were very instrumental in helping with a number of facilities, especially in Kern County and Tulare. I do want to ask, though, in terms of, as you've learned a number of lessons through the pandemic, are there ways to improve the coordination between the skilled nursing facilities, the county public health directors and OES, and the state? I know that, at least my personal experience of dealing with one facility, time is of the essence. And as an outbreak is happening, we're trying to determine if we need to move residents out, if we need to test immediately. We had clearly in the situation in Kern County, the leadership in the facility was COVID positive, and then there seemed to be kind of like a little bit of a delay in trying to address all those issues, and then eventually a strike team was sent, and it was probably a 48 to 72 hour time lag. And so I was trying to maybe understand maybe the lessons you've learned and how you've kind of addressed that, if at all.
Absolutely. Thank you for your question. In fact, the scenario you are painting are one of the very first outbreaks that I recall that we learned a lot from to be able to create a more resilient and more quick turnaround when it came to intervention. After one of those outbreaks actually that you spoke of is actually when we started to do the predictive analytics and creating an urgent needs dashboard that serves as our high alert system, which has been really helpful and effective. But to answer your question about what are we thinking for going forward, because I am expecting a second wave. I'm seeing Europe have a second wave. I'm seeing the East Coast and other parts of the United States having their second wave. I'm mindful that we have flu season. I'm mindful that we have mini holidays where we know that maybe not everyone is going to comply with, distancing and masking. And so with that, one of the initiatives that we're working on right now in conjunction with our hospitals and our skilled nursing facilities and our local public health is we are putting together what we would like to call our surge planning around a surge patient throughput system for your county. And so one of the things that I noticed back in August when I was traveling up and down through the Central Valley and meeting with counties is that I found that some counties did a great job of meeting with their skilled nursing facilities and a great job meeting with their hospitals, but it was very rare that I would see counties that had joint weekly meetings with their entire what I would call healthcare delivery continuum, looking at all of the transfer, discharge, readmit issues that can happen on a daily basis. And these are long-standing issues that, were probably there way before, COVID, but of course exacerbated by COVID. And so we are working on an all facilities letter providing best guidance and lessons learned that we had from the first wave on what are the best ways and having some concrete guidance around transfer and discharge of skilled nursing facilities as they enter and re-enter and go back and forth between acute settings and skilled nursing facilities, as well as readmit processes. When is it safe to readmit? When is it not safe? The other thing is setting up your alternative care sites. We have a lot of lessons learned from what would be best use of your alternative care site, and as well as how to best use your existing space, which is actually the safest space to be able to build out, and it allows you to flex staff and use your staff most wisely. And so we had a lot of lessons learned in that first wave that we want to be able to codify in writing and then be able to share it. I've been working with CAF and CHA, the California Hospital Association, to bring the hospitals and the skilled nursing facilities together to come to consensus on what this is, along with our infectious disease docs. And now we are at the point where we'll be sharing it the next week with our public health officers for their feedback. And once we have their feedback and their insights from the county level, then we will be issuing out this guidance, as well as then doing a webinar for both our facilities and our local health jurisdictions.
Okay, I appreciate that. I mean, I was just thinking that, at least from that experience, I was thinking that maybe a strike team would be sent first as we're trying to deal with a number of things. I know that when a nursing facility has a staffing issue, they go to the county. The county then tries to find staff. If they can't find, if the nursing facility and the staff and the county can't find staff, then they go to you. And then, of course, if all those things are exhausted, then you send a strike team. I was thinking that maybe we reverse it and send the strike team to stabilize everything, and then work out all the issues, especially when 24 hours or 48 hours is of the essence.
And we have done that exactly what you said. We have reversed it when the situation warranted it. So with that urgent needs dashboard, if we call and we contact and then we realize, wow, this is an urgent need. It's not about calling a registry. It's not about going through your MOAC system. It means we need to send a deployment. We do send a deployment. We have teams of either National Guard, CalMat, and Health Corps that will send in, stabilize the situation, and then work through whatever the root cause of what that emergent situation was.
Perfect. And then in terms of what triggers an in-person survey assessment, when you track the numbers, I'm sure as you've created this real-time data management system, does that, when something occurs or when you see something, does it automatically do you automatically send a team to do an assessment, or is it a case-by-case basis, or how does that work? How do you determine when you send someone to a facility?
No, great question. So we have a dashboard that we monitor 7 days a week. Facilities are reported to, they have to enter in their data, and as their data comes in real time, it gets correlated with other high-risk indicator data that we have compiled. We compare it with the past 3 years of compliance data, so if they've had any infection control, any citations in the last 3 years, that gets put in the algorithm. Any outbreaks within a 5-mile radius, we're going to be adding, as I said, recent flu data. We put in anyone that has a staffing waiver, that's considered high risk. Anyone who's having their very first case, even if it's just one case and it's either a resident or staff, that triggers us to immediately go in as well, because we have found that even though someone has the best laid plans and we've approved, not just reviewed, but approved their mitigation plans, we have also found that in that first 24 hours of getting that first case, they will either go with their plans and do their plans and execute them perfectly, or there could be a fight or flight situation where, fear or people start to call in, or there could be other issues that happen. And so that's why even just having one brand new case, that warrants an immediate visit and intervention.
Okay, so
and there's multiple other high risk. Okay. It's on our website. We have lots of different high risk indicators that we've added and will continue to add in. One of the things that just recently happened is we recently found that there were some citations or root causes of, for example, a facility not fit testing their staff. And that's a Cal OSHA reg. And so what we're doing now is seeing, okay, we have access to our compliance data, but if we can partner across different departments to see what other regulatory agencies that are also in these facilities, if we can partner and share other compliance data, that would also be a high-risk indicator to be able to intervene.
Perfect. And then in terms of my last question to you, and maybe Craig can jump in too, is a concern about testing. We certainly started early, and as Kern County, we went and used CARES funding to test and get a baseline. And then, of course, now there's a guidance that every week staff is tested, and then if there's no situation, it's every 2 weeks. I understand it, and please correct me if I'm wrong. What is our status of testing kits for residents and staff? I know that we were kind of short. I mean, we kind of were short of testing kits in the middle of the pandemic, and now it looks like we have enough. Is that true? Do we have enough to do testing on a regular basis to meet the 1 week, 2 week turnaround?
We do. Right now we have weekly testing in California. So we are, I would say, very aggressive in California with our testing. CMS did not state that testing weekly was necessary in all counties, but we felt to be more preventative going into the winter season, we require that everyone tests weekly, because we also have the capacity for that. So this week also, actually November 1st, we will be opening our first state-run lab, which is Perkin Elmer. And they will start with a capacity of 40,000 tests a day and build up over the next months up to, upwards to 150,000 tests a day. That on top of already our existing capacity so that we can expand testing throughout the winter months.
And Craig, do your facilities have access to all these tests? Are they comfortable in terms of everything that's happening?
They are definitely better off than they were. The PCR, and as you I think you know, Mr. Fong, there's the PCR test, which is the gold standard, which is what CDPH really wants. The turnaround time on those tests has improved dramatically, and they are able to get those in much better way. There are challenges still here, though, I would say. For example, some healthcare providers require the staff to go to their site to be tested, versus having the facility do the test in-house and sending it to the lab. So that takes time off of the staff time to get themselves tested in some ways. The other thing I would just mention to you is, in a number of states, they are allowing the use of the antigen test, and as you know, the federal government sent antigen test machines to every facility in the country. And those have very rapid turnaround, but they don't have the accuracy level is not as good. I think their turnaround is like 15 minutes or less. So most facilities are not utilizing what the federal government has provided them in that arena because the standard in California is higher. So I would say, I'm sorry.
Go ahead. Sorry.
I was going to say, I think that the PCR test is the gold standard, and so if someone tests under the CDPH guidance, if someone tests negative, they have to follow up with the PCR test anyway. So if they test negative with the antigen test, they still have to go get a PCR test. So yeah, the PCR is preferable, but it is much more costly, and it does take more time. And so I think that it has improved, but it could get better. And as Heidi said, the Perkin-Elmer lab, we were hoping that skilled nursing facilities will be a priority for the use of this Perkin-Elmer lab that the state has contracted with. It's going to turn around 140,000 tests a day, I believe. And so we're hoping that skilled nursing facilities and other congregate care facilities can be part of that.
Is the preference to test at the facility? I mean, would a mobile unit, is that the preference
Yes.
from your members? Okay.
Yes, definitely, because I think that is simpler in so many ways to be able to test at the facility versus the staff having to leave the facility or to go to, Kaiser, for example, to have their test. It would be much easier if they could do that in-house. And some facilities can do that, some cannot. But as you know, the state has required the health plans to pay for the testing for workers, and some of the health plans just require staff to require their people to come to their facility for testing.
And just, I guess the last question to Ms. Steinecker is, in terms of just hearing that, is the Perkins-Elmer lab, are they going to prioritize skilled nursing facility staff or residents or both?
Yes, we're going to be prioritizing all congregate settings, both ones under Department of Social Services and Department of Public Health.
Perfect, thank you. And this is maybe for Craig, but Ms. Steinecker, you can jump in too. My understanding is that there is like a 5-star quality rating system for skilled nursing facilities.
Yes.
Is there a need to update it or modernize it to make the information more readily available? Craig, you had mentioned that you would like kind of a one portal system for everyone to have information. Is that part of that discussion, or how would you kind of blend the two, or maybe address that transparency?
Yeah, the 5-star really looks at quality. That's really what it's focused on, and all the metrics related to quality. I think what I was really talking about was one place for that everyone can understand all the different guidance, because sometimes we have federal guidance, for example, on visitation. We have federal guidance on visitation, state guidance on visitation. The state has tried to marry that up, but as you heard Nicole and some others say, the counties though then have their own set of guidance. So there's no real one-stop shopping, and that's just one example. There are other requirements too, where some counties will place an admissions ban on facilities for a certain amount of time, and then the state guidance might be different on that. So I think, like I said, for people to be able to see in one place all the different guidance and requirements, whether they're federal, state, or local. The 5-star is really more for the consumer to find information about the quality of facilities.
Ms. Steinecker, is there a way to kind of blend it all? When you got the portal right now, or the dashboard that has that, would you be able to add everything that was, all this information to one, or is that is it better to keep it separate, I guess?
No, so we have, as far as all of our data and information, that's on a one-stop portal. But what Craig's alluding to is we have all of our state guidance or our all facility letters from DPH. Those are all on our website. We can also put all of our federal from CMS on there as well. The trick is having every county and every public health officer then link their health orders to our website, because right now, obviously every county can have, their own health order around COVID. And so it would be a matter of trying to ask that all of our individual counties would then have to agree to posting it on a state website or linking it, or we could maybe even link to all of the counties, but then someone would still have to then go through our website to then look at all the counties of what they're doing.
And in terms of that scenario, how does CDPH work with the counties if the counties go stricter or have a difference or want to do something different? Is there a collaborative process there, or how do you address?
No, absolutely, it's a collaborative process. There's been multiple times, I've called public health officers, and we've walked through, what our visitation guidance is, what their visitation guidance is, what are the concerns, are there ways for us to find some middle ground or a line? And I normally, we're again trying to take it from a science approach of, okay, if someone is 6 feet apart and they're wearing a mask and they're in this large ventilated space, what is the concern? Because we believe that that is the safest practice for them to be able to have visitation. And so we try to walk through what the issues are, but they are definitely, multifactorial depending on what is going on in that particular county.
Okay, so you don't discourage counties from acting separately, or did you just
Well, they have the authority, ultimate authority to do that. That's the way that our local public health government is set up. We do have Dr. Erica Pan, who is our acting state health officer, of course, and that is her role as well, to work with the counties in giving, working with the counties as far as direction. But no, we work collaboratively as best as we can to get as much alignment as possible.
Perfect. Craig, do you want to jump in there? I saw you jump back on.
Yeah, thank you. Just one quick thing. I think to show you how difficult some of this can be, what a county does on, for example, I'm aware of one county in the Bay Area that set one particular standard for admissions from hospitals. That has an effect, obviously, on the SNFs in that county, but it has an effect on all the surrounding counties, given that the Bay Area, for example, is a dynamic region where people move county to county pretty often. So that's one of the reasons I think it's a challenge just for facilities to operate in that kind of environment, and we understand clearly local public health directors have the ultimate authority here, but just getting a handle on the wide variety has been a challenge for facilities to operate.
So it's clearly recommended that the public health officers probably coordinate with everybody, I guess, in some ways. And that may be part of this weekly best practice of having a weekly kind of coordinating session where everyone can kind of share information. I guess that's the best practice that's come out of this. Well, thank you very much. I do have a question for my last, Nicole, the Ombudsman program.
Mr. Fong, so I was just going to say, I know Dr. Wasserman wanted to jump in if you were interested in hearing.
Absolutely. I'm sorry. If anyone wanted to jump in, I apologize. I just kind of targeted.
I'm just going to make sure it's okay with you.
Absolutely.
Dr.
Mr.
Wasserman?
Thank you so much. It's a little bit of a challenge from the being virtual. So, I actually had a few things I could comment on, but I wanted to preface it with a word I've come to understand over the last 8 months, which is the word stakeholder. And I want to commend CDPH for engaging the Geriatrics Council and CalTCM. We are not stakeholders. We are subject matter experts. And I really continue to be challenged by how the process works, where stakeholders have their input and the subject matter experts are not included in discussions that drive policy, that make decisions. And I'll give you a few examples. We didn't have geriatricians or experts in long-term care medicine on the testing task force, and that led to significant delays in knowledge regarding response to testing. I did want to comment on the overall mortality, and I do agree that the state has done an incredible job of putting into action a number of mechanisms and mitigation efforts that have reduced mortality. But I'm going to give you a couple caveats. Almost many of those recommendations were made by the experts in March and took till June, July, August, September, October before they were implemented. Lives could have been saved. And and the other thing that I think a lot of folks don't realize, as a geriatrician looking at the numbers for 8 months and the data, one of the reasons overall mortality has gone down is because we're improving in our efforts, but it's also because the most frail members of our nursing homes have already died. So, and they're not being replaced. And so the data, I'm not surprised that mortality rates are lower now. And the thing that concerns me is, while we've made improvements, vulnerable older adults continue to die every week. And I just want to make sure that we don't look at this as, hey, we're doing great. We are still losing vulnerable residents. We are still losing frontline staff. I also wanted to comment on the VA. I've been in touch with my VA colleagues from the beginning, and the VA is a great example of having geriatricians involved, having engaged medical directors involved, having enough staffing involved. Dr. Tom Yoshikawa was actually on one of our expert groups. He's at the VA in West Los Angeles that made recommendations around testing that we published at the end of May. So I think the VA is a great example of what works, and I strongly recommend we look at that as a positive. The other thing was, the question was asked about the vaccine prioritization. I actually had the honor of serving on the National Academy of Science committee that made recommendations for the allocation of the vaccine. And there is no question that frontline nursing home staff are one of the most important groups to get vaccinated. But we've actually convened another group of experts to make recommendations and give guidance at the state and federal level, because what you've heard today is the tip of the iceberg of the challenges that are going to occur when we start trying to implement the vaccine with the frontline staff. And again, I know this is not necessarily a forum for hearing all those details. I am happy to share that with your staff. But this is not going to be easy. And in fact, the way the federal government has set up the process, they have basically given responsibility to CVS and Walgreens to vaccinate nursing home residents. They've given each state the responsibility to decide how the nursing home staff are vaccinated. And that creates, and I've actually been in touch with some of the major vaccine manufacturers. They haven't been given a lot of great direction by the feds. So there's a lot more confusion around this than anyone is telling you right now. And I think that's really important. So those are the things up to this point that I really just wanted to make sure I made some comments on, and I appreciate the opportunity to share them. I know it's a little bit difficult in this sort of setting here.
Thank you, Doctor. Back to Mr. Fong. I think you had another question.
Thank you. Yes, I do share Dr. Wasserman's concern about a sense of urgency in trying to move as quickly as possible and learning a lot of these lessons. My last two questions to Ms. Howe is, I guess, have we quantified what the shortage is of labor staff, CNAs, throughout the state? Being from the Central Valley in a rural area, we certainly have even more challenges when it comes to shortages of nurses. So have we quantified that? And then I think you mentioned in your testimony that there was a backlog or an issue of testing or getting certified, the certified testing, not the testing of COVID, but the testing of actually getting these CNAs into the workforce. Can you elaborate on that? And with that, I appreciate the chairman's indulgence and patience.
So I'm going to start with your second question, and for the first, I'm actually going to defer to Craig and Heidi. The short answer is that yes, they have, but I think the real answer is much more nuanced. So in terms of backlog of testing, at the healthcare career pathway, we had students who graduated in May. Testing centers were closed. When they reopened testing centers, which are not super plentiful in general, they went back to the earlier appointments. So if you graduated in May, the students that we work with just began testing last week, and the remainder will take their tests next week. Now, why that's problematic, and we were all learning a new normal, but it's problematic because at the same time we were issuing staffing waivers to facilities, and we were saying you could have a nursing assistant, which essentially is a CNA who's halfway through training, come work with you. They get paid less. They can't do the full scope of work, and we're saying we're going to issue waivers for that, but we didn't prioritize how do we find our way through this. And I think that sometimes it's a way of thinking and it's a way of processing it that I think that we need to look at the full system. We relaxed regulations really at a rapid clip, but I think we didn't always see like what's the full effect of how that plays out. I also think it's important to note that this, as Heidi said, that there are, they've identified former CNAs who were certified who aren't working. Now, the reason they're working is a lot. It was, one, it's very challenging to work in skilled nursing facilities, but I would also say sometimes the culture and value for those folks who are on the front line is not always what it should. So when I hear from CNAs who went into the field and left, partly it's that they weren't successful in changing the culture. They went in desiring to be caregivers, but the system was set up where they had 10, 11, 12 people to care for in a given period of time, and they weren't able to do as effectively as they would want. Part of what our students learn is how to manage up, which I think is something we all learn, which is when they're in an uncomfortable situation with a supervisor, when they think there's a better way to care for a resident, how do they have that conversation respectfully? How do they retain that authority and engage in that relationship? It's also important to note, and this is what I think that you should really be aware of is, and I say this a lot, my grandmother was a hotel maid. She didn't finish elementary school. The maids of yesteryear are often the caregivers of today, and we are so lucky to have them. Many of them are the first in their family to be in this country, to be engaging in this kind of work, and they may not always feel comfortable challenging an assumption, right? Because there's a power difference there. We need to be mindful that the reason people are not working as CNAs isn't only about the compensation, but it is about the compensation. It's also about the culture that we value for caregivers. And to your first question, I'm going to slide away and let Craig or Heidi answer that.
Has the testing has the testing been addressed, or have they started again, or no?
Testing has restarted. Yes.
Thank you.
Very, very quickly, Mr. Fong, to your question about CNAs, the latest data from OSHPD, I believe that over the next decade, the state will need at least 30,000 more CNAs alone in the next decade. So,
thank you very much.
Thank you.
Thank you, Chairman Ting.
Thank you, Mr. Fong. We're going to go to Mr. Cooper next, and then Dr. Wood.
Just following up on my colleagues' concerns about the vaccinations, the 27% of the deaths occurring in SNFs, obviously vaccines are important, and I hope the SNFs will be prioritized. My mom is currently in a SNF right now, and just a shout out to CDPH. They have a website, CalFind. You can go look at all the different SNFs and see the ratings, complaints against them, and really get a good idea of what are the better SNFs around. So we actually got a really good one in Sacramento that we're very happy with. So thank you to CDPH for that. We're talking about, CNAs and getting them. It's a big issue. The funding's not there. It wasn't there for Medi-Cal. That's always been a big issue with it being capped. And anywhere, if you pay, the pay is decent, people will come. And the problem with recruitment and retention is the pay. And it's just a pervasive problem we have there. And, I guess my question to DHCS is, with labor costs being capped, why don't we fully fund the cost of labor for SNFs?
So the cost caps are included to fund up to the 96th percentile. So we made a change in the most recent to bring those cost caps up. And then additionally, we are through the statute, we are limited to a percentage rate increase annually.
Okay, but it's still an issue. That just happened recently, correct?
Correct. So that as part of my testimony, that was part of the changes that happened during the last budget cycle to change how we calculate those that methodology to increase that to 95 to the 95th percentile.
Okay, thank you. Thank you, Mr. Chair.
The chair stepped out, but he gave me the opportunity to ask some questions since I was next, so I'm going to go ahead and do that. First of all, these first couple questions are going to be for Ms. Steinecker. And when she pops back on here, I guess my first question is, we have the all facilities letter requiring that the full-time infection preventionists, is that happening in every skilled nursing facility now? Anybody out there?
Oh, sorry, I must have been on mute.
Oh, okay.
Sorry, I'll start over. No, thank you for your question, Dr. Wood. So yes, we did receive in June, all 1,200 facilities turned in their COVID mitigation plan. And even though there were a few that needed some reiterations before they could be officially approved, they all were eventually approved, and then we go out every 4 to 6 weeks to then verify that they are in fact doing so. And one of those pieces of that mitigation plan is that full-time infection prevention role. We have found instances and enforced where we did not find a full-time infection preventionist role. And because we do believe that that is a key factor here to have that kind of dedicated role, not someone who is, oh, I'm going to be the director of nursing and do the IP on the side, or I'm going to be a frontline nurse and be an IP on the side, but someone who is that dedicated role.
Okay, thank you. The new survey model with respect to the statement of deficiencies, can you tell me what that's going to look like? And will the surveyors be issuing citations and fines as well?
So I'm assuming you were talking about the quality and safety survey model that we'll be implementing post-pandemic.
Correct.
So currently we have our COVID mitigation plans that we are going in, like I said, every 4 to 6 weeks. And what we started to think of, well, how could we prevent this from happening, again, even in a post-pandemic world? Because pre-pandemic, we only entered facilities on the annual basis. And so we know that annual is not enough. If we learned anything, it's frequency and the power of presence and being physically present in these facilities more often, which garners better compliance. And so the quality and safety model, yes, they would be issuing enforcement actions, penalties, citations, all serving the same regulator model that they currently play. The difference is the frequency and keeping this level of heightened frequency up post-pandemic.
So as we move into new models here, the family, the resident complaints, are they going to be investigated through a new process? And what's the current backlog of pre-COVID investigations? How many, and how long is it taking to for those investigations to occur?
Great question. So when I was appointed in December 2018, I inherited I think it was around 25,000 backlog of all non-long-term care and long-term care combined complaints and facility reported incidents. Most of those of which were facility reported incidents, not complaints. And I would say it was about split 50-50 between non-long-term care and long-term care settings. We put together a root cause analysis of how this backlog even happened in California, and we're able to identify several root causes that were the main impetus for this, and then put together a comprehensive plan to reduce that. And when we initiated that and that what we called the Debt-Free 2021 plan in October of 2019. And in just a few short months prior to the pandemic hitting, we were up to 25% overall total reduction. That's not just of all the backlog complaints, but that was also including the entire universe, meaning everything coming in and everything that was backlogged, because it doesn't do us any good to just work off a backlog and then continue to accrue whatever is coming in. So that was the whole universe. Overall today, if we look at just the backlog, that was at, maybe 50% already taken care of. But what matters to me is that then when we hit the pandemic in March and April, while we were trying to garner enough PPE for our staff, while we were trying to come up with new infection control processes, as well as doing infection control federal surveys, then there was a few week gap there where we stopped, and then we focused other activities. So unfortunately, some of our backlog work had to be paused or dedicated during the first of those initial months. And then we were able to re-begin those complaint and FRI investigations. We do those investigations in tandem with or in parallel with our COVID mitigation. So when we go out onto a COVID mitigation survey, we also take any complaints or FRIs that we have for that facility. And then the plan is also post-pandemic, as we are continuing this level of frequency, to work off the backlog even more quickly by bringing these complaints and FRIs with us to those facilities. Because in order to do a federal investigation, it is required that you go on site. And so we're trying to reduce travel time, which was a big factor in our great state that has a lot of geographical challenges with, some mountains that we can't pass through the wintertime, et cetera, and a lot of rural areas that are harder to get to. The other piece with this is that we are looking to recruit, now that we have systems in place to do our work in a teleworking world and moving things from paper to electronic, we're able to also then have a faster time to task as far as getting information back to a facility, having a facility enter into a portal system where they can access their findings and be able to issue their plans of correction electronically. Prior to the pandemic, all of this was done by snail mail and fax. Even in 2020. And so this is a big, huge shift and lift that we are making in moving our survey processes, one type of survey at a time, onto an electronic process. So that is the other piece of this, is that this fall we are now working to move our complaint and FRI investigation process into an electronic format so that we can both work off the backlog, but more importantly, be able to do our work more efficiently and be able to deliver those findings in a more timely manner to the facilities.
Great, thank you. Next, I've got a couple questions for Mr. Cornett, if he's floating around in there. Thank you.
Thank you. Yes, sir.
Yeah, couple of questions for you. So we've talked about the need for more money for workforce, and we've got obviously challenges with our Medi-Cal rates and so on. So, nonprofit run facilities versus for-profit run facilities, they're all reimbursed the same rates, or are they not? Or are they not?
No one's reimbursed the same rates. It's a facility-specific rate, but it is also constrained. I would also say, too, there are very different patient mixes. For example, nonprofit facilities overall have about half the level of Medi-Cal patients that for-profit facilities do. So Medi-Cal for-profit facilities tend to have much higher Medi-Cal patient populations.
Okay, is that partial?
It's a little hard to do a direct comparison on that, but we have facility-specific rates. What I would say to you, though, is, and you heard Lindy mention this earlier, the way the reimbursement structure works is the costs are constrained. So even though there was an increase in the rates this last year, if you look at what the increase was, it is still, facilities across the board are still paid substantially less than what the full costs are that they report. By being able to do a direct pass-through for labor cost, for example, if the state could compensate for the full cost of labor, that would make a big difference in any kind of facility.
So the 10% bump didn't go to labor then?
No, the 10% COVID bump, it has to be used for anything related to COVID. It is going for staff bonuses and staff incentive pay. It is being used for overtime. It's being used for the additional cost of PPE, for technology. All the statute requires, AB 81 requires that 10% bump has to be used for COVID-related expenses. Most of those expenses, I suspect, are all going to mostly be in the area of staffing, because the staffing costs have been significantly more higher, with people out on sick leave, for example, or quarantining. Facilities are making use of the nurse registries. Those rates are about twice or sometimes 3 times more. They're having to pay a lot more overtime, and they're paying bonuses or staff incentive pay to keep staff on the job. So,
but even with that, they're low wages. So I mean, compared to the work, you know, I think certainly people on this panel believe that, you know, they should be higher. There should be higher compensation. So your for-profit entities are still making a profit here.
Well, if you look at the data, though, Mr. Wood, and we can provide you some of this data, the profit margins are extremely low, and around I wouldn't call it the profit margins, but if you look at the OSHPD data on this, they're in somewhere around the 1% range. And I would tell you the best indicator of this is how few new entries there are to the market. I mean, there are almost no new skilled nursing facilities in California each year. You can count them on one hand. And I think that's a pretty good indicator that you know, if this was a business where there was a lot of money to be made, you'd see a lot more people demanding to get into the businesses, and that's just not the case.
Well, but we also know there are related parties that are part of the tangled web of the way nursing home operators operate. So it's not unusual, from my recollection, that an operator might have its own laundry service that they contract. They might have another company that they rent from. And so that 1% doesn't reflect the profit of the entire industry.
But they're not allowed to make a profit off of the related parties. That's not, they're not allowed to do that. And as you recall, the audit that the state auditor did looked at that very issue too, and found no issues related to related parties 2 years ago. So.
Okay.
You're correct that there are related parties, but again, I just say that they're not allowed to make a profit off of that, and we're not aware of any. Again, given the auditor's report, we're not aware that that's an issue.
So and this is a theoretical question, which you probably can't answer, but I'm going to put it out there anyway. If there were an increase in the Medi-Cal reimbursement rate, do you think the industry would allow for the increase to guarantee that go to increase wages for workers?
I think that the industry would the profession would very much like to pay workers more. I don't think there's any question about that. What I've suggested to you is a direct pass-through, so that the state would fully compensate whatever the costs are of staff. Right now, the facilities are incentivized to put money into staff. That's their incentive now, because if their administrative costs, they're only reimbursed at the 50th percentile. For the labor costs, they're reimbursed at the 95th percentile, but just because even if you get to the 100th percentile, if you can get to 100% without a higher overall rate, that doesn't give them any more money. So because the rates right now are still very, very low, they can use more of the rate increase they have for staffing. They could do that currently, but they don't have enough money overall. If the state simply compensated with a direct pass-through for labor, that would make all the difference in the world.
Okay, thank you. Appreciate it. Dr. Wasserman, and these are my last series of questions. So, a couple questions for you, Dr. Wasserman. There we are. First of all, can you talk about SNFs and the third party issue? Kind of the need for transparency. I know about the audit. I'm the one who initiated the audit. So, but I'm curious as how this relates to the CARES Act and how the money from CARES Act has been disseminated and utilized by skilled nursing facilities.
Yeah, thank you, Assemblyman. Appreciate the question. So I think the concern that some of us have had is how the money from the CARES Act has actually flowed to facilities, and whether that money is being spent 100% towards direct patient care, whether it be hazard pay, whether it be PPE, whether it be testing. And I think one of the challenges is there's multiple ways that that money can, for lack of a better word, be siphoned away. For instance, you've mentioned related parties. The cost report doesn't capture all related parties, number one. So in order to really know some of these answers, we need full transparency on all of the related parties. Similarly, we need to get into a level of detail. For example, what are facilities paying, say, to a related party supplier for their PPE? Are they paying market rates? Are they paying over market rates? There's a lot of ways that the system, the money can be manipulated. And all at the same time, if some of that money is going away from the facility, it's not being used to pay our frontline staff who are putting their lives at risk. And I think that's of great concern. I think the real question here is we need a full amount of transparency of all these issues.
Thank you. Couple things other things you mentioned in your comments and recommendation in particular. One was 24-hour RN on duty. I was kind of appalled to realize and know and understand that a facility does not require a 24-hour nurse, an RN. We're not talking about a medical doctor. We're not talking about nurse practitioners. We're talking about an RN. So I'm going to guess that at some point, as things wind down in the evening, it's LVNs and CNAs, and you know, I'm concerned about that, and I would imagine that most consumers aren't aware of it. We certainly weren't aware of it, and you know, I just can't help but think that a change in that direction would be a dramatic potential improvement in the quality of care and the quality of the health of the residents, so that something early can be caught, and you know, things happen in the middle of the night. You know, I mean, that they clearly do in hospitals and wherever. I'm just shocked, quite frankly, that there isn't a requirement to have a nurse, an RN, in the building 24 hours a day, at a minimum.
Yeah.
Go ahead.
You and my wife, I was preparing for this, and she had the exact same reaction. She was like, wait a minute, I would have assumed this. And keep in mind, aside from the level of acuity of patients coming from the hospital, the residents in our facilities have multiple medical issues. And so there's actually a couple key points here. Facilities with under 99 beds are not required to have a 24/7 RN. And we need to change that because, as you said, in the middle of the night, someone's not feeling good. Who can evaluate them that has any licensed professional clinical expertise? And it must be a registered nurse. Now, we have to go beyond that because in larger size buildings, there may be an RN, though, surprisingly, even though it's required for there to be 24/7 RN for facilities greater than 100 beds, that doesn't always happen. And I think that is something that really needs to be monitored by the state as well. But even with an 24-hour nurse available, if things go wrong with a few patients at the same time, a few residents at the same time, one person is not enough. And that's where the 0.75 RN per 24 hours per resident per day comes in that Dr. Harrington spoke of. And you know, we really have to realize we're not running apartments here. We're running mini hospitals, and at the very least, we need a registered nurse who's available, who's not pulled in multiple directions. And I have to tell you, my heart breaks for the stories I heard Nicole Howe tell and others in terms of what's going on in understaffed facilities right now that we don't know about. And during COVID, there's a lot more complexity than we've ever had. And so the need for that 24/7, 0.75, full staffing is absolutely essential if we're going to provide even a modicum of care for our loved ones.
Great, thank you. You also talked about certified medical directors, and you also mentioned that the course is not terribly onerous. I mean, it's probably technically onerous, but as far as the time involved, it's a three-day course. And you know, I'm thinking about rural communities where often it's really difficult to even find a doctor who could, you know, who would be willing to be on paper the medical director. Have you thought you know, about other potential providers who might be able to fill a role like that? In some communities, you know, you may not find a doctor, but you know, maybe it's a nurse practitioner. You know, I don't know, but somebody who could be on site more, because my sense is that a lot of this is they're on paper more than they're on site, and it doesn't sound like from your conversation that they're really involved in decisions around the medical treatment of as far as the treatment of the residents. It sounds more like an administrative position where they kind of come in and, you know, sign a few papers occasionally, and then they're gone again. So now, if the goal is to have better care, the certification makes a difference, but there are probably settings where it's going to be really difficult. It's probably difficult now, but extremely difficult to get staff to do this.
No, that is a great question, Assemblyman. And first off, the course has online coursework, and then it ends with a 3-day sort of wrap-up that used to be in person but is now virtual. But, you know, rural areas have struggled regarding nursing homes for as long as I've been a geriatrician, which is over 30 years. And actually, back when I was in Colorado, we actually had a grant to go out to rural areas to try to help physicians deal with their older population. And so this is an ongoing problem, whether it's actually having clinicians who go to the facilities or having a medical director who is on site at the facility. And in rural areas, often the person who sees patients is also going to be the medical director, which has some of its own challenges. But I think one of the things we've learned during COVID is the opportunity to provide telehealth, telemedicine, virtual availability. In fact, the facility I'm medical director of, because of my age and I had asthma as a kid and my wife has some immunocompromise, I haven't been in that facility since the onset of COVID, but I have continued to interact with the staff and with the leadership of the facility. So there are many ways and in fact, I think one of the solutions here for rural areas is going to be providing telehealth to the nursing homes for both clinical care and medical director leadership. And, you know, to your point, most medical directors, unfortunately, get a nice stipend. And for that stipend, they go in and they spend an hour or two a month signing papers. That is not what the regs meant them to do. That's not what they're supposed to do. That's not what we need them to do. And one of the things that really I feel strongly about, you know, I'm a professional, you're a professional. If a physician doesn't have the tools and the training, then they don't have their own expectation of what they can do. But once you put in their hands the training, the tools, the skills, 95% of physicians that I know will take that responsibility seriously. And all of a sudden, you will have medical directors who are going to get more involved in whether a facility is up to speed staffing-wise in order to take complex residents. As one of my colleagues and I said early on in COVID, when the state actually tried to send COVID patients into nursing homes, my colleague and I said we'd stand in front of our facility and keep those people out, because as we all know, and the experts knew in March, the nursing home residents aren't bringing COVID into the facility. It's visitors, it's staff, it's vendors. And so if you have an engaged medical director who's actively involved with the administrator, with the director of nursing, and they know that that person is responsible for the clinical care, then you have an additional means. You have additional eyes and ears beyond the state surveyors, beyond everyone else. You've got professionals who are going to be part of the solution rather than part of the problem.
One final question for you, and thank the chair for indulging me here. Is the we talked about a little. We went back earlier. We talked about the transparency, about the need for transparency around how the CARES Act money may have been utilized. Was there what was the formula for what, how nursing homes qualified to get it? And I bring this up because yesterday we found out in our hearing on healthcare affordability that hospitals, often the hospitals that had the best balance sheets, got the lion's share of the money because of their Medicare populations and so on. Yet the hospitals that probably needed it the most didn't get that, didn't get anywhere close to what they needed yet. So it's it's those who have the gold get more gold, and those who don't. And so I'm curious, in this industry, how was the money disseminated? What did that look like? Did the biggest, wealthiest systems get the money, or was it fairly disseminated? I froze you up, apparently. I'm sorry. I don't think I had that power, but
It was a tough question.
Come back. Well, clearly somebody didn't like the question.
This is Omar. Okay. Thank you. Bye. Do you like being frozen if you're stepping in? they're restarting the system right now. Yeah.
Okay. I don't know if, did you hear my question before you froze there? It was just shocking, but anyway. We can't hear you though.
I actually heard the question,
Okay.
and then it froze.
Okay. All right. Oops. Hang on. We lost you.
You know, it's interesting when
Go ahead. We can hear you now. Go ahead.
So when the CARES Act came out, there really was no, they just gave the money out, and there really wasn't a lot attached to it. I think the larger organizations, as you said, with the most money, the most resources, probably were better able to access those funds. I always worry in these cases for the not-for-profits, the mom and pops, the sole-owned facilities, in order whether they were able to put in their request and get the money. In terms of, from my understanding from talking to actually staffers in Congress, there wasn't a lot attached to this. So the money just came out, and I think a lot of folks are beginning to look at what actually happened to it, and just as you are asking that question.
Okay, thank you. Well, I guess we'll continue to look at it then and see. So, have you heard? Is the federal government plan to do any audit on CARES Act and how it was spent?
I've actually spoken to staff on the congressional subcommittee that's looking at this, and it is my belief that they are going to be looking at this.
Okay, great. Thank you.
Okay, now we're going to go to Mr. Nazarian.
Thank you. Can you hear me?
We can hear you.
Perfect. Nice to see everyone remotely, and thank you, Mr. Chair, for holding this very important meeting. So I'm just sorry that I can't be there in person, but happy that I can join you remotely. My questions are primarily going to be for Mr. Cornett, Ms. Steinecker, and Dr. Wasserman. But before I get into it, I did want to also acknowledge Ms. Carmen, as did my colleague from Fresno. I find it interesting that she was infected in July and then had the misfortune of carrying that to her family and to her loved ones, and to hear about the challenges that her husband has been dealing with. When by July we had already had a couple of hearings, I believe at least one, if not two, and regardless of the hearings, we knew the alarming rates. So I think it just drives home the fact that even after we knew what was going on, that we had staffers struggling, and I do appreciate Mr. Chair for bringing on Ms. Carmen also to provide her testimony and her story. I wanted to get into a couple of questions. Mr. Wood and I seem to Dr. Wood and I seem to kind of think alike in some areas, so I appreciate his questions. And one of the answers Mr. Cornett gave was that for related party companies is that there's no profit involved. And Dr. Wasserman started touching on that, which before he was even going to say it, I was going to say, well, there's market rates that you could be setting and justifying. So how can you say that there is no profit involved? Is there something statutorily written? Can you please unmute yourself?
Yes.
Thank you.
Yes. Yeah. All facilities, they're audited, and the costs that they can be reimbursed for are audited. So the auditors exclude what they consider a profit on any of those third-party issues. The way facilities are reimbursed, they're reimbursed 2 years in arrears. So in other words, right now, what they receive right now is based on what they spent 2 years ago. Those are all audited, and any third-party transaction like that, third-party, the auditors will routinely exclude certain costs that show up on their, as a cost, and that includes any profit they make on those from those third party.
But you're free to put whatever rate for the staff. You're able to put whatever rate for the. Is there a cap on the rate for market rate on the rental or lease?
Yeah, I'm not sure I can give you that level of detail, Mr. Nazarian. I can get back to you on that. I just know that is how the auditing function works, though, that there are a lot of costs that are excluded from what a facility can claim. And then, like I say, on top of that, then each of those cost factors, depending on the part of the line item it's under, they will be reimbursed at the 50th percentile, maybe the 90th percentile, or whatever it is. And then on top of that, then there's a limitation on how much they can actually get based on the overall increase in the Medi-Cal rate. So they are constrained at multiple layers.
Now, I get the constraints. Constraints are put into place so that we try to provide the best service we can based on the dollars provided, and sometimes those aren't enough. But then there's always ways to maneuver around that. I mean, we recently in this last term took steps, for example, in the public education charter realm, where we said if you are an operator of a charter school, you cannot own the land that you're paying lease to, so that way it cuts potentially it basically takes away any potential motives of maybe paying a little bit more than the market rate or at the highest level of market rates for lease. Especially at a time like this, when market rates are at an all-time high. We know there's we are in an economic downturn. It's just we haven't felt the full effects of it yet. And so we can be setting prices right now, yet in the coming years, that rates may not be really the rates that should be paid because the market isn't there. So there's a lot of these gamesmanship that unfortunately can take place. So I don't know if my colleague Dr. Wood was thinking about this, but I think something along the lines of ensuring that housing, owner operators are also disinvested from ownership of the property potentially helps address at least one of these issues. I don't know if you would care to comment, Mr. Cornett, on that. But I'd like to hear it from you as well as from Dr. Wasserman.
Yeah, I would probably need to understand a little bit more what you're talking about. I will just tell you this, though. Many facilities around the country, less so in California, but many facilities around the country that have not been able to make it and have gone bankrupt over the last number of years, the cause of that has been the REITs. The REITs and the ownership of the land. That has been a major problem in many parts of the United States, because as the REITs have increased the lease cost, that is something that the facilities have not been able to manage, given that. So I would just say I'd be cautious about anything that we look at here, given the experience we've seen in other states.
So you've seen that in other states, but has that been the issue in California?
That has been an issue in California as well. I'm just saying I don't think it has been as dramatic in terms of forcing facilities into foreclosure and into bankruptcy as much, but it is definitely an issue here because we've seen that the REITs have run up the cost, to the extent that they don't. Now, there's different models. There's different models out there. Some facilities, I'm just thinking of one local facility here that's been a family-operated facility for 3 generations. That facility owner owns the facility and also operates the building too. In many cases, someone else owns the facility, owns the land, owns the dirt, if you will, and the facility, and the operator then operates the facility And then a major part of what they have to pay then is they have to pay the cost of the lease and usually to a REIT.
Okay, but I raise this because I think there needs to be a clear distinction between the person who owns the property and the person who's getting into the business and is going to make sure that every dollar is invested for the best interest of the healthcare outcomes and the best providing the best service through a model that they know works, rather than making sure that various costs are addressed, and then there isn't much left for the services that need to be rendered or provided. It's a very clear distinction for me, and again, that's why I took steps in the charter arena, education arena, to make sure that motivation was not there, and maybe that's something that we need to also. I'm certainly going to want to look at in the coming year, because we've seen this in other settings, in group homes, in many other settings, where the state will provide a certain amount of dollars, and I wonder to what extent some of these folks who conduct this business, once their property is paid off, will then quite simply even either sell the business or abandon the business. I'm interested now to know if there are any numbers in that. But this is, I'm going into areas that I wasn't even thinking of before this hearing. So I'd be very curious to explore that as well. Mr. Wasserman, would you like to comment on some of the questions I'm asking about the related party companies and certain practices and the level of enforcement?
So there's a bit of a time delay, so I was just listening to the end of the question. I'm actually really, really pleased that Mr. Cornett brought up the REITs. I couldn't agree more that the real estate pressure on nursing homes has been a long-standing issue. And if you actually look at some of the large, even publicly traded nursing home companies, the REITs sit on the boards of those companies. If you then look at owners of nursing homes as well as owning nursing homes and operations, when you have the same people owning the land, owning the real estate, and owning the property, as Mr. Cornett is very skillful, very correctly pointed out, they can apply pressure to the operations that can impact their ability to succeed and often end up leading them into bankruptcy if that pressure is too great. I mean, there are a myriad number of examples of this over the last 20, 30 years. So I actually think Ms. Cornett has really helped explain the fact that there are untoward pressures from real estate on the operations of nursing homes that are meant to be places where we provide care for very vulnerable people. And we really need to look for a way of either separating out this pressure, making changes to it, and I think there's a number of ideas that could be out there.
Very interested to discuss all these different pressure points and seeing how we can start implementing all of these different pressure points into some kind of an executable either policy or legislation that starts untangling certain influences from being able to deliver the best possible care as well. I think it would actually help also CAF within its own institution to be able to maybe make those separations. But by the way, since Dr. Wasserman, you're there right now, is you started touching on the vaccine task force and the geriatric medicine background. Do you know how many members there are on the task force?
So the governor has put together a work group to determine the safety and efficacy of the vaccine. And keep in mind, most of the vaccines that are out there that are being tested right now, only one to my knowledge has even ventured into nursing homes to have nursing home residents entered into those clinical trials. Even amongst the other ones, the upper age is often 65 or 75. We do have some that did go up to 85, and that's encouraging. So that's number one from a starting point. So when this vaccine gets approved, we really need to evaluate it. And in order to evaluate the safety and efficacy of this vaccine as it relates to older adults, we will need colleagues of mine, folks like myself, who have expertise in geriatrics and long-term care medicine, and there is not a single member of the vaccine work group with that expertise. The majority of the physicians on that work group are pediatricians, which I understand because pediatricians are very involved when it comes to vaccines. But when it comes to opining on whether these vaccines are going to be safe and effective for nursing home residents, for people over 65 in our other communities, we need experts to be part of that.
Thank you, Mr. Wasserman. On the issue of surveyors, if we can have Ms. Steinecker come back. Can you explain how you are handling enforcement right now?
Absolutely. So right now we are enforcing both complaint investigations, facility reported incident investigations. We're also doing COVID-19 mitigation surveys, which are state surveys, which are enforcement activities. And we are also going into facilities if there are high risk or urgent needs or outbreaks, and then enforcing and beginning a full investigation and survey when that warrants it too, when we enter into an outbreak situation.
Okay, so what is the end result when someone is not complying or not doing the things that you want done, or you have placed certain parameters for them to meet? What steps do you take next?
So if it is a state regulation, then we would cite for a state regulation. If there's a situation that warrants a full-on investigation, though, for like a complaint or a facility reported incident, then we use our federal regulations. And the federal regulations are stricter and have a little bit more weight to them than, honestly, than our current state regulations, because many of our Title 22 regulations need to be updated.
So in the last 6-7 months, have we shut down any facility? You do have the authority to do that. Have we
Yes.
shut down any facility? How many?
We have done, well, I will tell you, there's a couple of different situations. So there is a revocation process, which is one way that we do it. And we did do a revocation of a license completely in Pasadena. We also have done what we call joint temporary evacuations, meaning that where we have worked alongside with a public health officer, where often the public health officer is doing the health order and we are there on site working with them to either decompress a facility, evacuate a facility, and then depending on whether or not they are able to stabilize the situation, then they may be able to resume services. And then another enforcement action that we're taking is putting in temporary managers. So that is an instance where we have a situation that we believe is unsafe to the point where we need to instill a state temporary manager. And that temporary manager then takes over operations on behalf of the state until, in some cases, it led to an actual revocation. In other cases, they were able to stabilize. They had their citations. They moved through. They corrected their actions, and then they were able to resume operating their own facility, and then we remove our temporary manager. So there's been multiple different types of, I would say, on the continuum of enforcement.
Do you have numbers, going back to my question again, about how many? Do you have numbers on where you are with the 3 or 4 levels that you just described? How many in each category you have at this current state?
So you mean just for the pandemic period that we're talking about since
Yes.
March? Okay.
Yes.
Yes. So we have one facility that we have done a full revocation, and we are going through the court process of that piece of it, and they do not have operations at that facility. We have about 3 or 4 different facilities that we have entered into either a temporary manager position where we have had to take over the operations temporarily, but I can get that exact number for you. And then we have had a couple of, I would say only a handful of situations where we have had to, I would say again, I think it was only 2 or 3 times that we actually entered into a partnership, let's say, with the public health officer to do an evacuation or decompression in those situations of a skilled nursing facility.
And so are the numbers, since March, have the numbers of locations that you need to take any steps with,
Like
leading up to potential revocation, has it been the same this year as in any other year, or has there been a increase in the number of
increase? So that's an increase. It's unusual that you would actually have to get to the point of revocating a license. In fact, I don't think it has been done. When I asked my team when is the last time that this kind of stance had been done, it hadn't been done in years, not even from, I think, my predecessor, but maybe the person before that. So it was a very unusually, I guess, strict course of action that we took, but I stand by that it was the safest course of action. And it was one that we also were able to make sure that we were able to transfer those residents safely over a period of time. So we will go through that enforcement process and see that through the entire court process that takes.
So where do the clients of a revoked place or a shutdown place end up going?
They are transferred to local facilities. And we work with the local public health officer to make sure that we have safe spaces, particularly with COVID. It's even more difficult, right? Because you want to make sure that if you have COVID positives, that you are transferring to a location that already has a COVID positive wing, or what we call a red zone, already enacted and cohorted appropriately. And then you're making sure that you test and do medical evaluations to see if there's anyone that needs to be transferred to a local general acute care hospital. And then you're also doing evaluations and testing to see if for those who are COVID negative or have no exposures can then be appropriately transferred. And you really have to, I mean, of course, our first course of action is always to try to what we call, enforce and ensure that there is safety at the location. But if it is so unsafe, we must be able to have to go through a transfer plan with a local health officer.
But how do you deal with capacity issues? If the other vicinities in the area are already at capacity, how would you be able to introduce new individuals into the care of the adjoining facilities?
So luckily, we have not had that issue. There is capacity, and there has been capacity in all of these situations. And in fact, with the case of Pasadena, I've also worked with the local public health there in Pasadena multiple times, and Dr. Go has expressed that they have enough capacity to where they do not need this particular facility to come online again. And it was in a state, I think even just the physical age of the facility and the how it was even set up is not something that we would entertain having new operations in at this time, in the way that the actual facility is set up today.
Okay, so is the Pasadena location now shut down, or while they're going through the court process, can they still operate?
No, it's completely shut down. And all of
Okay.
their residents are at other nearby facilities within Pasadena.
Okay. I at least since Pasadena is in an urban dense area, I suspect that the families and loved ones were working with maybe the state to make sure that their loved ones are getting to a nearby location. So it just raises a lot of other issues. So what are the current testing protocols for individuals who are leaving skilled nursing?
So leaving to go home, or?
Yes.
So if a patient has the right, or a resident has the right to be able to discharge, and so we do not have, specific rules about testing if they want to discharge to go home. You meaning that they are going to actually stay home, not take a pass, go home for a time period, and then come back?
But I was thinking in going home permanently, but being discharged. But in either circumstance, I'm wondering, is there some kind of a whether an introduction or exit out of the containment of the building, is there testing that gets done to make sure that we know what state the individual is leaving in?
So the most common example that we have where a resident is leaving temporarily and coming back is usually when they're going to a general acute care hospital for an acute episode of some sort of issue, and then they're readmitted back into their skilled nursing facility, which is often their home, so to speak. And so for that, we do not require 2 sets of tests. We would just require 1 test so that they will have the results, so that they know where to cohort that individual. So if they're test positive, then they can go into the COVID positive cohorted wing of a facility. If they are considered an exposure for some reason, they can go into the yellow, into kind of a quarantine type when they're into the facility. And then if it was tested negative, then there's potential that they could go into the COVID green zone of a facility.
Are you familiar with any circumstance where a resident was leaving and going home, and potentially and may have been infected and it was found out later?
Not in a skilled nursing facility. Now, I know that we see a lot of that, and I've heard some of those issues more so in Department of Social Services buildings, which are resident care for the elderly, RCFEs, as well as assisted living. In assisted living facilities, you often see more people, of course, having the freedom to kind of go in and out. It's less so that you would see that in a skilled nursing facility where the residents are more in the acute range of illness and usually not, leaving or going home. But to that point, as we are gearing up and preparing for holiday season and a season where we do tend to see potential passes or for skilled nursing facility residents to go home for a certain amount of time. We will be issuing an all facilities letter in the next few weeks that we've been drafting presently with our infectious disease docs about what are some best practices, about what could be potential when they come home or if they come back to the skilled nursing facility, if they have some sort of pass that they go off, on how to best make sure that they are limiting that exposure to others in the residence.
Okay, changing direction a little bit. back to the staffing issue. Are you continuing to offer staffing waivers for 1 year?
So right now we have emergency staffing waivers that are 90 days. And each 90 days, and even during that 90-day period, we have the ability to reassess or revoke if we feel like the situation was abused or not, that there was a unsafe situation in a facility. And so we do have that process right now. We do post online on our website all the facilities that have those waivers, and we are processing those as they come in. We have about 400 of the 1,200 skilled nursing facilities who requested an emergency staffing waiver in the last 90 days. And I know that we had approved already, I think, somewhere around 150 of those. And then there are others that we are requesting more documentation. And there are others that we will be denying based off of their performance in the last 90 days.
Okay, so it's 90 days, and how many times can a waiver be received by the same company?
There's not a limit on these emergency waivers, but again, as the days go on, the question then becomes, what did you do in the last 90 days? What staffing, agencies did you work with? Why do you still not have staffing even 90 days later? Particularly when we know as a state, granted the state can leverage, the ability to have larger contracts and be able to draw staff from out of state, whereas maybe a small mom and pop skilled nursing facility in a rural area may have more difficulty leveraging or finding contacts or finding new staff. Those are the people that we are looking at for, staffing waivers. But other facilities should be able to come up with a staffing plan in those 90 days to be able to resolve the situation on their own.
So do the companies that are asking for these waivers, have you noticed a certain trend? Do they offer hazard pay in order to maybe entice or attract employees? Are they offering increased pay, any type of motivation or incentives? Are you noticing any trends? Is that one of the factors in the questions that you ask to see if they're also taking the certain appropriate steps in order to make sure that they're maintaining a certain level of care that we're establishing standards for?
We do ask for them to provide a narrative and explanation of what methods they have already tried, whether that is what kind of marketing or recruitment have they done, what is their current their pay structure, so that we can kind of get a sense, is it below market, is it at market, is it above market, and we ask for what other types of agencies have they tried outside of their region, if they're a rural area, and we ask for that in that process. We also ask if there have been any recent layoffs and anything that might warrant that there was some indicative reason that they could have had more staff.
So have you noticed if a facility is paying hazard pay or increased pay, do they fall into the category of coming to you for waivers?
That's a good question. I mean, that's something that maybe we could see if we could get data from the industry to figure out who is doing the hazard pay, because that I don't have a pulse on to be able to, or even a way to gather that data, but we can see if we can take that back, because I think that would be an interesting correlation to see if that is a true factor that's actually being helpful.
Okay, well, I'd love to hear this from, if Mr. Cornett and Mr. Wasserman want to offer their thoughts on these questions about hazard pay. I'd love to hear it from them as well.
Yeah, Mr. Nazarian, virtually every facility I'm aware of, and there's again, there's 1,224 facilities in the state. I mean, so it's hard to kind of say this uniformly, but virtually every facility or every multi-company facility that I'm aware of is paying some kind of hazard pay. They're doing it in different ways. They may have different way of doing it. In some cases, paying a few extra hourly dollars. In some cases, doing lump sum payments. They're all kind of all over the board. But almost everyone I'm aware of, they're paying what is required in the market. And the market is obviously tight already, and it's gotten tighter, and they're trying desperately to keep people on the job. So,
right, but paying that's a very relative response, though, Mr. Cornett, right? What you say you're paying in the market could vary, given especially the geography and the demands of the state. So
no question. No question. So, yeah.
Given that relativity, what's I'm still interested to know number-wise I'm interested to see if there's a correlation between companies that are getting waivers and which companies are providing the hazard pay, and if there is what the nexus of that is, because I suspect a lot of folks who are going to be getting paid the hazard pay and the further incentives are going to want to continue staying, or will even migrate between facilities. But I'm interested to hear from you and to some extent DDPH to verify that.
We'll follow up with you on that. I will tell you though, it might surprise you, because I'm aware of facilities, for example, they've indicated to us they're paying much higher wages. They're also paying hazard pay, and they will get some days they will just get a number of staff who will just call in and not be able to come in for different reasons. Now, part of that is things that are difficult for the staff to deal with too. Everybody's kids are doing remote schooling. I mean, if they have family members, all those things are difficult issues under any circumstance. And with the shortage we have in workforce generally, this is just double down on the problem.
I have to ask for a hall pass from my wife on many occasions. That I understand. Would Doctors Harrington and Wasserman want to offer some thoughts on this?
We good? Yep. Yeah, I definitely, this goes to the issue of how we keep and maintain CNAs in our nursing homes. And there's a bit of a false narrative out there that it's hard to get good people, it's hard to keep them. I will tell you, I've been doing this for 30 years. If you find really top-notch facilities, 5-star facilities, very successful facilities, you often find CNAs who have been working there 20 or 30 years. So here's the deal. It's about leadership, it's about respect. So if you have the right culture in your facility and your CNAs feel respected and acknowledged and cared for, and then the other side of that is you've got to pay them a living wage. If they have to work 2 jobs, it's going to be really hard for them to be that committed to your facility. So I think it's a combination of adequate wages as well as respect and strong leadership from the facility in terms of absolutely respecting and appreciating the CNAs. So I think, part of the theme here when it comes to CNAs is we have a lot of work to do. This is not somewhere where we just say, okay, let's give them hazard pay, and now they're going to come. I mean, if they're not treated well, then they're not going to come. And again, I'm not saying that there's any necessary across-the-board generalization of CNAs not being treated well. What I am saying is this is something the industry really needs to look at. And I would, sort of double down on everything Nicole Howe said about how we train these folks and then how, as facilities, we treat these frontline heroes that we need so desperately. And I think if we treat them well and pay them well, I think we will not have the staffing issues that we're talking about here. And one last comment on the waivers. To me, I get the waivers from a business perspective. I don't get the waivers as a clinician. When you're basically saying we cannot provide an adequate level of care for our residents, but we're giving a waiver because the facility has trouble getting them, I as a clinician, I just don't understand that.
Thank you. And Mr. Chair, thank you for indulging me. I really appreciate you giving me the opportunity. I only have one more question, but it seems like someone wants to chime in.
Yeah, did Dr. Harrington want to
Yeah.
check?
Yeah. Yes, could you repeat the question? It's very hard to hear on this remote system.
The question generally was around the issue of the shortages in staffing and offering waivers, and whether or not when you make hazard pays and or incentivize greater pays, are in facilities where there are hazard pays or increased pays to staff, are those also the facilities that then do not request waivers? I wanted to see if there was some kind of an interrelation that we've been able to notice or trends from the relationship that we can notice and start seeing who's asking for waivers, and if they're asking for waivers, have they exhausted every avenue, which is also incentivizing employees to get paid more so that they do come to work. And so that was the gist of it. That was the idea.
So, is this on?
Yes, it's on.
Yes, I had some difficulty understanding the question because of the remote, but generally I wanted to say that the shortage of workers is a function of two things in addition to some of the things that have been mentioned. It's a function of pay, because if you can make more money as a janitor or in a fast food company with less stress and less danger, then there's no incentive to go to work for a nursing home. And secondly, it's the workloads. We know from our research that a nursing assistant should only have 7 residents at a maximum on the day and the evening shift, and maybe 12 or 15 at night. And yet most nursing homes, many of them are asking nursing assistants to have 12 or even 15 residents to take care of, so they simply can't get the work done. So it's extremely frustrating, and with the low pay, it means that's basically what causes the shortage. And then when you give a waiver, it creates a spiral down. So these waivers have been counterproductive. And a good example of that is on October 9th at the Watsonville post-acute center. That was a very high-risk facility, and they ended up having 61 residents that got infected and 9 deaths. And that facility only had 3.4 hours per resident day, so it was below the state minimum, and 15 minutes of RN time per resident per day. And they were given a waiver, and so they spiraled down on their staffing and ended up having to have the National Guard come in. So we think, you know, there has to be a way to get the wages increased with pass-through arrangements and to get the workload down, even if it has to be phased in over time. Hazard pay would make a huge difference, especially, you know, in this current environment. And we know that many nursing homes have given out hazard pay, and that has really, it has made a difference, although we don't have any research data on it, but just anecdotally. So this is, it's a fundamental problem here, and I think I want to just say that I think a lot of the deaths that we've had, the over 4,000 deaths, could have been prevented if we had asked nursing homes to increase their RN staffing and their total staffing during the pandemic, and asked them to really increase the hazard pay and the at least $3 an hour more on overall pay. It would have made a big difference.
In the instance that you said the National Guard came in to a facility, who covered their cost?
I don't know the answer to who covered their costs, but it's just a symptom of what happens when you have low staffing and put the nurses in an untenable position. And then when they get sick or they're exposed to the COVID, they're not going to be able to work, or they're going to leave work, and leaving the facility with no other alternative but bringing in the National Guard. And I'm not sure who paid for them, but I doubt if it was the facility.
It actually was, it was the facility.
Yeah, the facility is billed anytime that we deploy emergency staffing, whether that's health corps, emergency staffing through our National Guard or through our CalMet teams. All of our deployments for emergency staffing, the facilities are billed that staffing.
And is that billing at the same rate as the staff would have been getting paid, or is there a difference?
Great question. So we bill at the state rate that we get those state contracts for, and we pass through that cost directly. And so oftentimes these state contracts are very pricey. They're expensive. And so it is definitely not in a facility's interest to have emergency staffing in that kind of bill.
Mr. Nazarin, can I just say one other thing just for context, because I think there's been a lot of good testimony, a lot of good points here. I want to mention, to the extent we have more staff in facilities, could well be a good thing. I don't want to question that at all. But I do want to point out, if you look at the history of this pandemic, if you have more staff and they don't have PPE and they don't have testing, that you're probably still going to have problems. And that's what we saw. If you think about the pandemic, we've had facilities that had very high staffing levels, were able to maintain high staffing levels, and still had spread because they didn't have PPE, they didn't have testing, and they did not know, based on the early guidance. The early guidance said that you had to be symptomatic or you were spreading. That was wrong. And we found that out, that happened later on. In addition, when we had admissions from hospitals of folks who were already positive, residents who were already positive, that were asymptomatic, they were spreading. So to the extent we have more staff, yeah, that could be an advantage on the one hand. On the other hand, with the fundamentals we've seen in this pandemic, especially the first number of months, that would have probably not made any difference, unfortunately. Thankfully, we're in a better spot. Thankfully, we're in a much better spot on PPE. We know more about everybody knows more about the virus, but this has been a statewide problem for the entire healthcare continuum.
Craig, all due respect, you're saying things that raises a lot of other questions. And so, again, I want to be respectful of my chair's time, you know, because I have just one more question, but this is leading to certain other areas as well. I mean, what you're basically saying is that if, you know, we don't do one set of things, then we won't have to worry about some other things. That's what I heard. At least that's what I heard. I don't know if my other committee members heard that as well, but you know, we were having struggles as we've had multiple of these hearings in order to address the shortcomings of the Department of Public Health and why we're not getting certain standards into place. You know, now, if we can meet those, which they haven't been met yet, but as we're making headway into meeting some of those, you know, there's a part that the industry needs to play as well and make sure that it's meeting these challenges as well. So help me out here because that answer raised more questions than answered.
Well, I think you heard the statistics at the beginning as to how much better we are doing right now, how much better we're doing relative in time, but how much better we're doing than other states. And
that doesn't necessarily address the question, Craig.
Well, it does. I understand that, and I think
many of the vulnerable people passed away already. So we've already there's already been a disservice.
And again, we mourn everyone who's passed away in any facility. And again, as I tried to say at the beginning, we celebrate the caregivers we have here. And unfortunately, that has not happened enough either. There's been an awful lot of focus on the hospital caregivers and not nearly enough focus on the caregivers in our long-term care settings as far as we're concerned. But I just want to emphasize again, though, in this pandemic, some of the things we're talking about, given what we've learned since then, this was a perfect storm for us, frankly. We had a pandemic we didn't know that no one knew anything about that was affecting the healthcare structure across the board. We had nobody had any PPE, and we didn't have any testing. Those things were all a real problem and put everyone back on their heels very, very badly for quite a number of months. Now, thankfully, things are much better on those fronts than they were, particularly on the testing and the PPE, as you've heard already. So, and I think it's one of the reasons you're seeing things better too.
And Craig, I must take exception to what you're saying, because part of it is we're also coming off of one of the best economic performing periods of time. We've had continuous growth in the economy. So when we're saying there was a perfect storm, yes, there was a perfect storm, but the reality is that perfect storm was preceded by 9 years, if not more, of economic growth and benefit. And so that's the time when we make the appropriate precautions and investments to make sure that we're ready for instances like what we've been dealing with for the last 7 months. So that's where I'm having a bit of a challenge accepting that response.
I couldn't agree more. I couldn't agree more. And we were very pleased with what happened in AB 81 this year to give our facilities rate increases. They were not nearly enough to cover the cost. So even with the good times the state had, our facilities did not see that. And as I say, we're being reimbursed right now. Our facilities are being reimbursed based on what they had to pay 2 years prior to today. And given what's happened on all cost in the last 2 years, they're still very far behind. So, but I certainly concur with you.
So I'll just ask my last question, and Mr. Chair, thank you so much for giving me the time that you have. How are we ensuring that oversight isn't simply looking at infection protocols, but it's also addressing the quality of life inside the skilled nursing facility? So, and I welcome responses from Ms. Steinecker, Mr. Cornett as well as Dr. Wasserman as well?
Well, often when we are in a facility, so we're required as contractors of CMS and by our duties or state surveyors, is that even if we're in a facility investigating whether or not there was a fly in a soup, if we see something while we're in that facility that warrants concern that has nothing to do with why we entered the facility in the first place, we have the right and the duty to explore that and to do an investigation on that. So even if we're in a facility that is about something else, so an infection prevention, it could be a complaint, it could be anything, when we're in there, if we see something, then we must cite it and go forward. And I've had many examples of times, unfortunately, where we have been in for an infection control survey and we witness and see, because a lot of these surveyors, they know these facilities, they've been in there multiple times throughout the years, and they see a resident who looks like they've lost weight. And then that's the first thing, an indication that they start to do a fuller investigation of nutrition and to see if there's a quality of care issue and to see if there are more deeper issues going on in the facility. And so actually most of our infection site or infection surveys, they have sometimes landed with what we call immediate jeopardy situations, or an IJ is what we call them, where we are issuing an immediate jeopardy situation that has nothing to do with the pandemic, but everything to do with poor leadership and poor quality of care. And so that's just, one way that we're able to see it, but the other way is actually partnering with the California Department of Aging. And we actually reached out to the Ombudsman program and asked, what are the facilities you're concerned with? What are the facilities where you have had issues with in the past, so that we could then target and prioritize visits to those facilities as well. And I think the more that we can communicate with the Department of Aging and our Ombudsman program even further, we could be able to do a lot more because they will see something in a different way as well. And since, and we're providing as much technical assistance to get our partners, our ombudsman back into these facilities so that they can be eyes and ears as well.
Ms. Nazarian, I need to hold off on one thing. We have to close down the Wi-Fi or the public comment in San Francisco at 5 p.m. So there's one person in San Francisco who has come to give public comment. If you could hold on for any last question, let's let that person give public comment. Thank you. You have 1 minute.
Good afternoon, Mr. Chair and members of the committee. Thank you for the opportunity to comment. My name is Felicia Barbato, and I have been working with the California Department of Public Health for 8.5 years as a health facilities evaluator nurse. My job is to ensure the residents of California are safe within the skilled nursing facilities. I am also a proud member of SEIU Local 1000. I would like to briefly describe what it has been like to work during COVID. I have been well aware of the poor infection control practices and quality of care in many of our nursing homes prior to the pandemic. The high rates of death in these facilities during the pandemic unfortunately comes as no surprise. When I saw what was happening in Washington State in February, I knew what was headed our way. Some coworkers and I requested at that time that we be fit tested with N95 masks so that we could be prepared to enter nursing homes to ensure safety. However, in March, we were told to stay out of the facilities because they were not safe. Fit testing began for us in August, 6 months later. We are the point of contact for the state to ensure the safety of nursing home residents. But because of the lack of planning and proper equipment, we were not able to go in early in this pandemic to protect our most vulnerable. I believe many lives could have been saved if we had been able to do so. We have to be honest about what has happened and correct it now. Thank you.
Thank you. Thank you for your patience. Any other public testimony in San Francisco before we have to, I guess, shut down there? Let me also just thank Dr. Harrington for participating in the hearing. I had a question for her as well, but I'll wait till I'll just contact her directly. Back to you, Mr. Nazarian.
Thank you, Mr. Chair. That was my last question, which was basically, ensuring, while we're ensuring oversight, and it's not simply just looking at infection protocols, but also looking at addressing quality of life. And I wanted Ms. Steinecker, Mr. Cornett, and Dr. Wasserman to all have an opportunity to respond. We already heard from Ms. Steinecker, so if Mr. Cornett and Dr. Wasserman want to chime in, I'd welcome it. And thank you.
Didn't know who was going to go first. I'm trying to get the question. Remind me the topic.
I defer to Dr. Wasserman if you have any other questions on that. But Mr. Nazarian, just like I said, just to let you know, the surveyors are in the buildings at least every 6 weeks now, in some cases more, to check on the mitigation plans and to see how facilities are doing. And so just in terms of oversight, I'm not sure that answers your question, but.
Okay. Yeah. No, I'm good. I was thinking about what that brave soul was sharing with us. I would like to say that as of late, my organization has been working closely with CDPH. We've actually begun to develop some education and training for surveyors around working with or asking questions of and interviewing the medical directors, the consultant pharmacists. And so we actually really appreciate those efforts. And we think, to Ms. Steinecker's point, that one of the challenges of the survey process is how you impact poor leadership in a facility. And I think you begin to impact that by asking more questions of all the leaders in the facility, the administrator, the director of nursing, the medical director, the consultant pharmacist, and such. So, look, I think there's a lot that we can learn from what's happened over the last 8 months. I think there's been positive movement in terms of looking at how we approach these processes. I absolutely agree that we need to continue down that path, and we can find fault in what we've done wrong, but I think what we need to do is start figuring out what's next. And I will share, CalTCM has actually submitted a grant proposal through the CMP funds to provide leadership and management training to facility leadership teams. And I feel very strongly that during a crisis, leadership is absolutely essential. And I don't think there's any space amongst all of us to recognize that if you don't have strong, solid leadership in a nursing facility, especially during a pandemic, you're going to have problems and you're going to have poor outcomes. So I think that's really one of the key areas for all of us to be looking at.
Ms. Nazarian, are you, does that satisfy you? Are you done?
I'm done with the questions. Thank you, Mr. Chair.
Thank you. I wanted to just ask a couple questions. I wanted to go to Ms. Howe and then to Dr. Wasserman. And unfortunately, Dr. Harrington, we had to shut down San Francisco, but you all advocated for, more nursing coverage, nursing assistant coverage, increase in wages. I think you've heard the response from Mr. Cornett in terms of the challenges and the difficulty in the shortage of people to go higher. I guess how, you have this recommendation, how would you advise us to implement this, and what is stopping this from being reality?
I would start by telling about a facility that I know of that did pay hazard pay when they had a very significant pandemic that resulted in dozens of deaths. And they paid their CNAs more while they were in outbreak. And as soon as the outbreak was over, they lowered their pay. And I think that speaks to the way that so many CNAs are treated. So I think it's a multi-pronged approach. One, we need to immediately change the compensation structure. And while some of it certainly can be pass-throughs, I also support what has been talked about around really understanding the compensation structure at skilled nursing facilities and where the funds are really going. Because let's remember how they're being paid. It's the people's money. It's our money. So I think it's about talking about revitalizing and revolutionizing how CNAs are trained for their existing jobs. I think it's also about building stackable pathways for CNAs to enter other fields like LVN, RN, surgical technologists, other fields. We need to really look at what that looks like and make sure we're not having these redundant pathways and making it possible for people. I also think we frankly need to look at what skilled nursing facilities look like as a workplace, which is exactly what Dr. Harrington was talking about, which is that 12 to 15 CNAs on night shift is much more akin to what CNAs are caring for on day shift when there's the highest level of needs. We need to look at how folks are actually able to do their work. It's backbreaking, intimate, and important work, and if we're making it impossible then, of course people don't stay. I also suggest surveying those CNAs who are licensed, who are no longer willing to work in the field of, let's not simply say, oh, it's because of kids, or oh, it's because of that. Let's actually ask them, what was hard about this work, and what would it take to get them back into the field?
So could you comment, just before we leave that subject, on the shortage? I mean, you heard Mr. Cornett talk about a 30,000 person shortage in the workplace, and I mean, I understand your feeling, or just your advice about how to reshape the workplace, but let's say we could do that. How would we get more people into that work, into this field?
Yeah, I think it's also partly about, we could look to some of our schools. We have medical technology high schools, and we funnel young people into that field. Well, you can start with anatomy in your first year, and by your senior year, you could be working on your CNA program credentials so that you leave with entrance into community college and you're already a CNA and you have an existing job. It also would be that the CNA training can take time. If you're doing it well, it's an extended period of time. There are many programs that are only a few weeks, and I hold that they are not appropriate or enough training. I think it's about looking at that like, gosh, can we do paid internships for people while they're training to be a CNAs? I think it's also expanding the number of programs that are available. As you pointed out, in some rural areas, it's very hard to become a CNA because there's not an accessible school. I think it's a multi-pronged approach, and I don't just think it's one thing, but I think part of the problem is that, we hear, the CNAs are mandated reporters, and so often they report to us anonymously because they've made other complaints. They've attempted to address issues of care that they know are wrong that aren't really taken seriously at the licensing level. And so I think it's really about saying that the CNA, you have the resident, and then right outside of that, you have the CNA in terms of the locus of care. And we need to value those things simultaneously and have them help us to reshape the industry. I know that that's a bit of a sort of a soft answer for you, but I think that's where we have to start, is that, unfortunately, all the numbers and the data, we don't have that much of an insight into what CNA's lives look like. I also would say if we're serious about controlling the disease of COVID in long-term care, we have to get serious about the lives of what our CNAs are doing outside of work, which is that many of them themselves are living in sort of highly packed housing with other family members who are also caregivers. They're also still doing all of the things that we have to do, like grocery shopping, like kids. Like, if we want to get serious about controlling disease, it's not just about the workplace, it's what we're expecting that person to do outside of work.
And I fully understand that, but I think we as legislators have to figure out what procedures or policies we can implement to really scale, to be able to scale to solve this problem. This is not just this is not just an issue with a facility or 10% of the facilities. This is a systemic issue within the industry. And we've heard, we heard from Mr. Cornett talking about there's always the constant drumbeat of Medi-Cal reimbursements. And if I have a nickel for every health professional that complains about Medi-Cal reimbursements, I could close the $54 billion budget gap. So, we're very sympathetic, and I think your points are extraordinarily well taken. But I'm trying to get something that we can go do, right? So I think that's our challenge, because I totally agree with you. I think what you say makes sense, but how do we scale that? How do we grow that? It's versus just having a great story and having 30 people being impacted, which I'm not saying it's not important. It is very important, because that's how you do things. But when you have 1,200 facilities and you have a shortfall at each of those, and this is something all across the state, how do we tackle that?
So, sir, I would say I have a plan for that. We have a program that is replicable across the state to allow more qualified CNAs to enter the field. It requires a financial investment of training. It requires wraparound support services for these individuals. And it requires us looking at our regulatory and education system to knock down some artificial barriers in its place. So what I would say is, the way I'd follow up is, I'd like to share the curriculum that I have with you.
Sure.
And share our outcomes. We're actually evaluated by a firm, and talk about what that looks like. So I think it's multi-pronged, but I think it's a continuing conversation of, if I have permission to reach out to your staff to share this with them and continue this conversation of how it can be replicated across the state.
You have more than permission. We'd welcome it. And how much would it cost?
So I can tell you what it costs on a local level, and that's highly nuanced based on what the adult education staff are paid. And also, we also are supported by a John Muir Community Health Fund for the short term. At the state level, I have to look at that. I would say I don't think it's actually more expensive than we're already providing for people in two ways. First of all, in terms of there's already WIOA dollars being allocated to adult education and supportive education services. I think it's about specifically earmarking those for entry into the allied healthcare.
So this is budget committee. Whenever people give me words, when I ask for a number, I just need a number. What's a number? Because when you put words into a budget, that means you got zero money. So you could get that if you want, but how much money are we talking about?
I don't know. I have to go back and look at that. I could make up a number, but it's 100% made up at this point.
Well, that's not. I can make up a number too. So
right, and I don't want to do that. So.
Okay. Well, do you have a sense of how much it is per person? And also, just so you know, you mentioned sort of adult ed. Just realize that we've in many ways started transitioning adult ed into community colleges, because we had that debate versus adult ed in K through 12 districts or high school districts, or K through 12 districts, and adult ed in community colleges. And the reason we transitioned, and I think your point's well taken, but the reason we transitioned is during the last recession, when K through 12 districts had to make a choice between cutting K through 12 or adult ed. They uniformly across the board cut adult ed. So that's why we decided to kind of keep it with community colleges, since they serve adults. So I don't know if that changes your opinion of that.
Well, I would say during the school we work with during the last recession, what they actually saw is people flocking to CNA training programs, because those were jobs that that had openings and that could be filled, and people who had done other jobs, including professional, management level, really needed to work. So in terms of student costs, it's between $1,800 and $2,500 per student, depending on a couple variables. Okay. But that covers food, comprehensive support services, training. So I hear your point around realignment, but I also think we need to look at both community college and adult education.
It was fine, but I advise you, talk to Mr. Cornett, who's right next to you. Besides being the, CEO of the, health facilities, he's also a budget guru, so he can help you with that. But I think, look, you just heard there's a 30,000 person shortage, and you have a plan to scale that. I think it is an opportunity. There are other fields. We have plenty of industries where we don't have a shortage. We're actually doing what we call this magic word called transition. So this is not what we're hearing in this hearing, and I really would urge, the two of you to talk. Also, for you to talk with our committee, we'd be more than happy to understand how to think about this. Dr. Wasserman, just going back to you, just the same kind of question you mentioned. More RN coverage, more resources. How do we do it? I assume if the facilities had the money to do this, they'd already be doing it. So how does this become a reality?
Okay, can you hear me okay?
We can hear you great.
Having a little feedback here. We good? Okay. So actually, I want to frame this two ways. First, the nursing home industry is at an inflection point right now, and we have to do something. And one of the best examples I'll give you is what Assemblyman Wood did with his bill. We recommended the second week of March that every nursing home in the state have a full-time infection preventionist. And I will tell you what we heard from various folks was, we can't afford that. And my response was, you can't afford not to. There is something called investing in quality so that you have better outcomes and you save money. And so I question the premise that certain investments in staffing necessarily are going to lead to a net loss of money. And, we have not-for-profits that do fine. And so I honestly think the industry needs to look in the mirror and decide, as both Mr. Nazarian and Wood mentioned, where does the real estate flow? Where do the funds flow? I said in the assembly hearing to the health committees back in June, the large nursing home chains in this state and across the country could easily have leveraged their assets to acquire abundant PPE and testing in March and April when the experts were saying that's what we needed. They had no fiduciary responsibility to do that, and they didn't. Actually, I want to take a step on that.
So are you
there
saying,
are some
Dr. Wasserman,
operators
Dr.
who
Wasserman?
did.
So are you just saying they could bring in more people now, they're just choosing not to because of profit? Because we haven't seen the same amount of infection rates or problems in the nonprofit sector that in essence may be dealing with even a poor clientele. So is that what you're saying? We could do it right now, it's just the profit motive's getting in the way? I'm just trying to understand what you're saying.
That's a great question. And actually there is data showing fewer outbreaks, fewer deaths in not-for-profits versus for-profit. And look, I'm an entrepreneur. I believe in the profit motive. At the same time, we can't abuse that privilege. And I think the industry really has to take a hard look at how much money it wants to make and where it wants to make it. And that's where all the other transparency issues come in. I don't think the state should have to spend extra money. And in fact, the reason we recommended that full-time infection preventionist back in March was that wouldn't cost the state a cent. And in fact, it would take people that the nursing homes already had, because every nursing home already has an infection preventionist. It's just that they're typically pulled in 12 different directions and not allowed to do their job. And to be very honest, in a lot of ways, there was just resistance because folks don't understand that you have to invest in doing the right thing and providing quality care in order to be profitable. That is what I believe, and I think that is sort of a mantra I believe in. And I too would be happy to spend time with your staff too, in terms of, I love numbers. And I do believe that this industry can survive, but they're going to have to make a huge decision in terms of how much profit and where that profit's going to be if they do want to survive.
Thank you, Dr. Wasserman. Just for 1 second, I know I have more questions, but we've had some very patient members of the public who have to leave. So I am going to go out of order and allow people for public comment to come on up in the room in 4202. I'm looking at the public, and people want, come on up, come to the mic. And we'll give you a minute, then I'll continue my questions. Go ahead, sir.
Fine day today, Professor Assemblyman Ting and the rest of the committee. My name is Patrick Bankert, and I live in Sacramento. I should say fine day to y'all. Perhaps your grandma had you paint Easter eggs and place little gifts and little eggs for you to find in the backyard. Perhaps your grandmother was as beautiful as mine. Perhaps you shared food and sang together. My grandmother passed away before I experienced some real hardships. It's embarrassing to say, but basically I was tortured for 11 months straight, 24/7, 6 months straight, 24/7. People broke into my apartment, put substances on the ground, put a topical drug on my doorknob, which basically tortured me with some kind of brain virus. I don't know. It was difficult. It was more difficult than I can even describe. But I just want y'all to know that I'm not sure about giving medication or the vaccines to the elderly, because I feel like maybe we should maybe come to a better understanding about what's all in it, because I think there might be some kind of biotechnology or something maybe in it. I'm not trying to blame anybody. I'm not mad at anyone. I know the doctors are perfect the way God made them. I think y'all are perfect the way God made you. I think we all are. I just think part of being perfect is part of maybe making mistakes, because sometimes we can go through life and people can tell us we're not good enough because we're not good looking enough, that's me, or rich enough, that's me, or smart enough. I doubt y'all have ever been through that, but I know that's me. And
Thanks.
I just think
If you could wrap up, please.
I just think we're all good enough the way God made us, and to the people responsible for what I've been going through, I would just like to say, maybe we can work on building a culture where all people can be their best. And I think y'all, whoever's responsible, I think you're probably the best at what you do, and you're probably very courageous too. And I'd like you to deliver your feedback calmly and respectfully and in person. And if not, I'm not willing to listen. Thank y'all very much. I think you're perfect the way God made you.
Thank you. Appreciate it. Any other public comment?
Oh, a minute. That's what I get, and I appreciate the flexibility. And I just want to make sure I can be heard and that I can be seen. There I am. I frequent this room. Welcome to day 238 of Flattening the Curve. It is evident you have continued on this path to ensure receipt of CARES and other grant funding. I'm here to tell you that we are not interested in CARES money, because CARES money is blood money. It is the blood money of our small businesses dying and the forced isolation of our most vulnerable, the elderly and other populations in skilled nursing facilities. No amount of money is worth this sacrifice. The National Center for Health Statistics emphasized that most deaths are not by COVID, but with COVID. The state has combined the data, setting the rates by COVID artificially high. Only 6% of those deaths had no comorbidity on their death certificate. In addition, the PCR test further inflates the positivity rates due to false positives. We are isolating people to the point where they actually want to die. How can you possibly be okay with this? Cases are not illnesses. This is the first time in history we have tested healthy individuals for traces of a virus and used these tests as rationale to decimate our economy and prevent people from experiencing love, joy, and connection. Frankly, I am horrified by the language I'm hearing about people needing to submit to the flu shot and the COVID shot. Mandated medicine is a disgrace now and forever. We know this from history, and this is why we have signed treaty after treaty edifying the importance of informed consent. There is no more basic liberty than the freedom to decide what goes into our bodies. The Universal Declaration of Human Rights was adopted in 1948 after World War II in response to its medical and ethical horrors. Similarly, the Nuremberg Code in 2005 on behalf of global consensus, which involves 193 countries, including the United States. UNESCO adopted the Universal Declaration on Bioethics and Human Rights. Article 6.1 consent declares any preventative, diagnostic, and therapeutic medical intervention is only to be carried out with the prior free and informed consent of the person concerned. And you cut my mic. You cut my mic.
We gave you more than your time. Thank you. And we also allowed you to go out of order. So thank you. And again, the public comment we're asking for is on the budget committee hearing that is happening today, which is it's an oversight hearing around skilled nursing facilities. Thank you. Next person.
Good afternoon. I'm Lisa Coleman with the California Long-Term Care Ombudsman Association. And I thank the legislatures for bringing and keeping their eyes on what's going on in long-term care facilities. This continues to be my passion, and I'm glad it's yours now too. I did want to speak to Assemblymember Ting and his specific question on numbers. So earlier we were talking about the VA facilities and how they have a very low rate of COVID in their facilities. They also have a very low rate of CNA turnover. They have a very a longevity of their staff. They're paid state workers, and with state workers they get benefits. And so we're making that connection. And I don't think anybody here would argue that a VA hospital gets richly paid on a per diem on a daily basis. So there's dollars to compare. Where does this need for 30,000 CNAs come from? 2 years ago, when the whole waiver program for staff shortages was first brought up, the number was 14,000. We only have 1,200 skilled nursing facilities. Where does this huge number come from? So I do think that Nicole Howe's program is amazing. I've talked with those folks. One of the things in the budget committee I know is very difficult for you in general is we spend money over here, but we do not see how we're saving money over here. I have met with many of her participants in those programs. If they weren't in this program learning a skill, we would be paying for them on welfare. We would be paying for them in other ways, incarcerations and in other social services. There is pride in doing a job well done, and I think this is a program that should be invested in across the state. Thank you.
Next speaker, please.
Good afternoon, Chair and members. Thank you for convening this really important hearing. My name is Alexandria Smith-Davis. I'm with Leading Age California. We represent a continuum of senior care providers, including skilled nursing facilities. I'll be brief because I think the panelists did a good job of describing all of the issues that we're facing. And I'd like to highlight workforces we've talked about all day, all afternoon. We also feel that we need to invest in our workforce. The LTSS Center in Boston recently released a report explaining all of the benefits of increasing wages for our direct care staff. We echo those benefits, including lower turnover, increased happiness in their jobs, and in addition to workforce, I'd really like to thank Heidi for her leadership at CDPH in the last 8 to 10 months and working with our facilities and creating an environment where we can ask questions and convene weekly meetings, including the one Dr. Wasserman's group helps convene. Again, thank you so much.
Thank you. Any other speakers from the public? Come on up.
Hi, can I
have the attention, guys, for just 1 second? I will be quick. I actually don't have too much to say today because so much has been said already. It's 4 hours. I mean, you guys have been talking for literally hours. But I do have 2 noteworthy things that are worth mentioning. One, it is so cold in here. I have been freezing the entire time. And I think someone somewhere should do something about it. Number 2, frankly, we are not going to have too many more living members of the boomers, the X, or the silent generation if we do not stop this. I don't have a better way to describe this other than fucking bullshit. Stop the lies, the media manipulation, the immense cover-up, the catastrophic distraction that a vaccine is going to magically undo the fact that our governor targeted nursing homes to murder so many vulnerable residents by stuffing COVID-contaminated people in with the elderly. Thank you.
Any other comment from the public? Okay, seeing none, I'd like to go back to my questions. I'm sorry, was any other members of the public in the other facilities around the state? Seeing none, I'm going to go back to just my questions. So, even Mr. Cornett, is Mr. Cornett still there? Thank you for your patience. So I think you heard some of the, we heard about the shortage. I don't know if you want to talk about where that 30,000 number came from, but then also just the feedback in terms of the industry, in terms of treating the workforce better, better wages. The question is are the wages lower than they should be because the industry is a for-profit industry versus a non-profit industry? If you could address some of those issues.
Sure. Yeah, that number is really from OSHPD. So it's a dynamic number, but that's from the state agency, the state that collects that data and does those analyses. So that's number one. By the way, on Ms. Howe's program, I'm aware of that program, and we have members of our association in Contra Costa County that participate. She mentioned some just earlier, and I think it's a great opportunity to try to bring more people into the facility. And everything I've heard about from our members is it's a great program. I would just say to you that to get the workforce we need, it's going to require a lot of different arrows in the quiver. There's not going to be one way to do this, but it's going to require a lot of different things. Salary and programs like Ms. Howe mentioned, and other programs that the state can promote through the community colleges. We're working with the community colleges constantly to try to get more workforce training programs, particularly for CNAs, but also for LVNs and RNs as well. But there's no question this is going to take a multi-pronged approach going forward. Certainly, and I would say certainly, the salaries are an issue. I just want to, but let me just emphasize again on this issue about the profits and so forth. I mean, right now, and this came up earlier from Mr. Nazarian about the REITs and the profits. I want to make sure that you're aware of this. The Medi-Cal reimbursement system for capital cost, they're based on what's called a fair rental system. That's calculated by the state, and it does not take into account actual leases, mortgages, and that kind of thing. So that's all excluded already too. The Medi-Cal, as I said, doesn't pay for any related party profit either. That's all removed through the audit process. And ultimately, though, after you make all those adjustments, the amount of money that then is left is even constrained even more right now because facilities all report their actual cost, and their rate is based on their actual cost. Again, audited, a lot of cost excluded, profit excluded, and so forth from the third parties and so forth. And then after that happens, then their rates are reduced even more by at least 6% right now because of the Medi-Cal rates. If Medi-Cal wasn't cutting that back, we'd be able to fully reimburse facilities for their cost. Their cost would still be, constrained to some degree, but they would have more money then, I would say, to be able to pass along in salaries. Now, the best way to deal with this, in our view, is for the state to pay directly the labor costs, the direct and indirect labor, outside the budgetary cap. That would mean that DHCS could fully reimburse facilities for their actual labor cost, which would allow facilities to increase their wages and retain workers, provide higher quality care in general. So we think that's the number one thing I would say that could have the biggest impact.
Thank you. And then you had mentioned earlier PPE and testing. Has that issue been resolved in terms of adequate PPE, adequate testing?
I would say it is much better. I don't want to say it's resolved because we still see shortages every once in a while. Sometimes for a while it was gowns, then it was a mask, then it was gloves, and it's gone back and forth. And I think the supply chains into the so much of this PPE is manufactured outside the United States, and there's been huge supply chain issues. So I would say the situation is better, but it's still not totally perfect. As you know, though, SB 275 is going to require the state to build a much bigger stockpile of PPE, going forward, and I think that'll help in the future. On the testing, testing is certainly improved, but again, test results are most valuable if the results can come back in 24 hours or less. So there are still some challenges in that arena. They're certainly better. The turnaround time is certainly better. As I mentioned earlier, though, there are logistical issues with the testing, though. In some cases, for the staff testing, they have to leave the building to go to their healthcare provider. Some facilities are able to do the testing in-house, take the test in-house, send it off to the lab. Hopefully it comes back in less than 24 hours. So I would just say to you, it's improved. I don't think it's totally there at all. But I did mention the Perk and Elmer lab, and Heidi mentioned that too. That may help going forward.
Yeah, that's what we hope, is that the testing lab will help, and hopefully you've seen improvements with PPE since we went into a variety of contracts with different suppliers for that.
That's right.
So then just going to Ms. Steinecker or Ms. Harrington, I mean, you heard Mr. Cornett's comments about the Medi-Cal reimbursements, the shortage of that, that being a major issue. How would you address that issue?
Assembly Member, this is Lindy Harrington with the Department of Healthcare Services. I mean, I think you have to consider it in the broader scope that we have to be fiduciarily responsible. So you do need to look, and again, we have in the calculation, it's up to the 95th percentile. So we think that does do, really incentivizes the utilization and the investment into labor. Additionally, as we look at, we do calculations, and right now we reimburse approximately 96% of the cost for Medi-Cal. We do something called the upper payment limit calculation that we have to provide to CMS to ensure that our rates are not above the upper payment limit. And as part of that calculation, we look at facilities as a whole group. And based on the state fiscal year 18-19 calculations, we were reimbursing for Medi-Cal only approximately 96% of the total cost.
Okay, and then, but I guess you have the facilities saying that's still not enough.
Well, that again, just Mr.
Sure, Mr. Cornett, go ahead, please.
Yeah, Mr. Chairman. First of all, that goes back to 2018-19. That's wages and so forth have changed a lot, but that's also based on the reported cost. What I'm suggesting is, if we want to get more money into salaries and wages, this is the way to do it, because right now, and as Ms. Harrington I think described accurately, there is a constraint on all of this. They can pay up to 95%, but that doesn't mean they have more money in their base to pay. It just means that that's an eligible area where they can reimburse that area versus administration. Administration, they can only pay up to the 50th percentile. So even doing that doesn't get them any more money to pay. the real budgetary constraint is what the annual increase is, annual percentage increase in the rates, the rates are.
Got it. And then just going back to Ms. Steinecker or Ms. Harrington, I mean, my understanding is nonprofits are about 10% of the 1,200 skilled nursing facilities. They overall have performed better. That's my understanding. Please correct me if I'm wrong. Do you have any feedback as to why that may be the case? Is it the population? Is it the resources? What, if anything, do you think is the difference?
So some of the, at least from the research I've seen, some of the poorest performing facilities in the for-profit world are actually our smaller facilities, not our large corporations. And we believe, best guess from what we've been looking at early research, is that they lack the ability to, if you're a small mom and pop small business who was impacted by COVID, particularly if you're in a rural area, you may lack even resources within your county or your region, or you may lack the staffing that can actually be able to go out and leverage and try to find additional staffing contracts that are outside of your areas. But at least that's from what I've seen from the research, from what I've been looking at so far. I do want to make a comment about staffing in general, since this has been such a huge topic and it is such a root cause of quality and safety in a facility. And that's that I agree with Nicole Howe and some other panelists here that this is really a multi-pronged, multifactorial issue. It's both cultural. It's not just, I mean, yes, wages are a major factor, but I think the issues run deeper than that. And therefore, the solutions need to be broader than that. And as I said before, bringing in Department of Education, and I really like Nicole Howe's, comments about, even starting as young as in through K through 12 education, having voc ed programs and things of that nature. Prior to my position here at California, I was working abroad in Europe, where I had the opportunity to see a variety of different ways that they address cultural generations and mixing them together, having kindergartens next to skilled nursing facilities, having college students have free room and board if they work at a skilled nursing facility, just a variety of different approaches that we can learn from, both in our state and internationally, of some best practices.
Thank you for that. Okay. I am done with my questions. I'm seeing if anyone else. This has actually been really appreciate everyone's patience and thoroughness on this hearing. The fact that it's not me by myself or me and Mr. Obernolte by ourselves. Appreciate all the members for sticking around and all the members who participated remotely, and very much appreciate all the people who sat from the administration as well as all our sort of expert witnesses. Very much appreciate all the testimony. It just demonstrates, I think, the importance of the issue and how strongly we feel about the issue. We do appreciate, one, all the work that has been done to improve the situation at skilled nursing facilities, but also, I think Mr. Cornett brought it up, most importantly, to all the people who are working on the front lines in the facilities each and every single day. We very much appreciate that. We know how difficult it is and how difficult these circumstances are. So again, without seeing any other public comment or any other further questions, we're going to adjourn. Thank you very much.